You can go back and fast forward. You cannot fast forward me in person, but yes, you can
But I
after
don't need
the
to record right now unless I want.
correct.
Okay.
Thank you. Thank you. All right. Okay. So
I just, it was like, wait a second.
thank you. I appreciate that. Now you're gonna have to remind me to stop recording when I say something inappropriate.
Check, no.
All right. My little presentation thing isn't working. So
You just hate being on camera, is that why you're like getting out of?
no, I love being on camera because I'm a narcissist. Totally kidding. No, I just want this thing to work the right way. What's going on? If I have to do it this way, I'm gonna be annoyed. Okay, anyways. I may have to stand back here. This is how it's basically broke down, okay? It's the numbers are slightly different, but if you look at percentages, whatever, it's basically gonna be the same, all right? So the patient care section, remember the very first semester, and I told you how important that book was, and it was 30% of the boards, right, or close to that. I mean, it's 33 questions, okay? So not 30% of the boards necessarily, but it's still a big portion of it, okay? Again, these numbers are slightly different, and they don't give them to you on your little packet anymore, but it's basically what it's going to be. Okay.
I still have it on the ART.
I think they have this, but they don't break it down any further than this. Okay, so the next one will do that. So within the patient care portion, the part we're going to cover in this next hour, it is broke down this way. Okay, this is what they do not give you anymore.
And I am zooming.
Okay. All right, zoom in.
Can you see
Okay.
cross media?
There, hopefully that helps. So 30 of those questions, this is how they are. Okay, so when you're like worried about pharmacology and you're like, oh, I gotta know all these things about pharmacology, 3 questions are gonna be of pharmacology. Okay, are they gonna ask you all these super intense, like weird questions about pharmacology? No, they're gonna ask you about ionic versus non-ionic contrast. And what do you need to know about non-ionic versus ionic contrast? Why? Why? Yes, because the closest to the body's osmolarity is non-ionic contrast, which is why a radiologist would choose that over the ionic contrast. That's all you need to know about that. Okay, good with that? Okay.
Are you able to move that down a little bit so we can see it on Zoom?
Is it not showing you the screen, the whole thing? Like
No.
move the camera down or move the
You need to move the laptop more.
it's not like it's. Does that make sense? That's all it's all on the screen.
No, our view is just you and kind of the wall behind you. We can only see
It's not showing you. Oh,
you can just see a tiny corner of the screen.
I only want you to see me. I'm sorry. Thank you for letting me know. Let's make this, let's share a screen. That would help. You're laughing at me? Okay. Thank you for letting me know. Okay. Now let me see if I can do. Can you see that slide now? Only one slide?
So perfect. Thank
Is
you.
that better? Okay,
Yeah.
now I understand. Okay.
Thank you.
Thank you. All right. Sorry, I gotta move this because this will drive me nuts. Work, little mouse. Work with me. Okay. Okay. What is this garbage? Get out of here. Okay, informed consent. We all understand what informed consent is? Which? Yes.
Quick question, are these slides on, like, are they available to us?
I don't know, but they are not giving you.
Cool.
Okay.
I appreciate it.
Where are they? Where are they?
Tanya's class.
Okay, it'll be on this recording that you have, but I'll.
Sure.
Tanya should have, they should be on it because they're giving them every year, but if not, I'll make sure. Okay.
Thank you.
All right, so informed consent. Which patients do we give informed consent? Every patient, yes, thank you. So there's different types of informed consent, right? We are telling, it can be verbal, written, or implied. Okay, verbal, every chest x-ray that comes through, we get verbal consent from them. We tell them what we are doing for that procedure, kind of tell them the risks, right? Like in a chest x-ray, we don't really have to express too many risks, but if we ask them about pregnancy, then we're explaining, okay? We're informing our patient of what we're doing, and we're getting verbal consent. By them saying, okay, or going up to the bucky, means that they consent for that procedure. All right, when do we need written consent? Anybody know? Any invasive procedure or contrast. Yeah, anytime we're going to be penetrating the body with anything, a scalpel, needle, whatever, we need to get informed consent, or sorry, written consent. Okay. All right. Implied consent. When does implied consent come? Yeah, somebody that may not be able to speak to us saying they give consent, or write sign saying they give us consent. So somebody, an unconscious patient, for example. That is implied that they would want that service rendered to them in order to save their life, right? So we take it as implied consent. Okay. HIPAA. We all understand that HIPAA, what it stands for, but we think, what's the first thing that comes to mind when we say HIPAA? Patients what? Privacy protection, yes. Okay. We always forget the portion that indicates that the patient's right to health care, right to receive those services. Okay, HIPAA also covers that. So the Health Insurance Portability and Accountability Act also covers that every person should be able to access health care, regardless of their financial status or anything else. That doesn't mean that we deny them just because they can't pay for it, right? Has that happened in our country before? Yes, within the last 10 years? Yes, currently, probably somewhere, right? But it's against the law. We cannot refuse treatment to a patient, okay? We have to figure out if they can pay for it after. What's the first thing that they ask a patient when they check in, though? If they have insurance, how they intend to pay, right? Like, that's what they want to know, right? But that's okay. They can ask those things, but they still cannot refuse them the services. They have to provide it for them, okay? So remember that one, because you will have. It's hard. Can you refuse services? Right, said? Oh, cannot. Yes. Yes, we cannot refuse to give somebody the care they need. Even if it's somebody that is treating us like garbage, we cannot refuse them the care, right? Can we hold off on care if they're being abusive? Of course. Okay. All right, torts. We have intentional torts and unintentional torts. What do we think of when it comes to a tort? Do we ever use that terminology? No, not in layman's terms, right? Okay, but a tort is an injustice, injury, or misconduct that is considered private or civil. Okay, meaning anything that we do in the hospital falls under these tort laws. Okay, so an action that wrongly causes harm to someone and is dealt with in a civil court. Criminal. What would be a criminal court? Not paying your taxes, things like that, right? Yeah. Okay. All right, so intentional torts. Examples: false imprisonment, assault, battery, invasion of privacy, and defamation. So some of these things that are covered under our HIPAA laws, okay, will end up being, and you don't have to write them all down right now. We're going to go over each one, okay? So false imprisonment. An example of this is using restraints on a patient without authorization, okay? What if your patient come in for service, they're bleeding a little bit, they have a wound, and they are getting treated and they decide they don't want the treatment, they want to leave. Can we keep them there because we know it's what's better for them? No, that would be false imprisonment, okay? Unless that patient was intoxicated or something like that. The boards will never ask you a question like that. They'll just say, what is false imprisonment, and give you options of what would be considered false imprisonment, okay? Or the definitions, basically what they're going to be asking for. All right. Assault. A crime of trying or threatening to hurt someone physically. So we don't have to vocally say it, but we could be intentionally trying to do it. That's assault. Okay. An example of that we always use is threatening a patient if they don't cooperate. We're going to cause them more pain, right? If we do it in a threatening manner, we can say, we need you to cooperate because if we're trying to move you or pull on you, it could cause you more pain. That's not threatening, right? But if you're like, if you don't hold still, I'm gonna make this really painful for you. That becomes a threat, okay? Same thing, different language, okay? That's assault. Now, battery is carrying out a threat a lot of times, okay? They usually go hand in hand. So assault is the threat to do it. Battery is actually doing it. Can you have battery without assault? Yes. Any one of us could come up and just hit somebody for no reason, without actually warning them, right? That's battery without assault. Okay. Invasion of privacy. So anything that we would be doing that would violate HIPAA as far as their right to privacy would be an invasion. So disclosing confidential patient information to unauthorized individuals. So that whole question that you had about if you can access your sister's thing, information, right? Hospital records, whatever, medical records. We have to have permission to do so. The boards may give you some scenarios, not likely to be that specific, but they may say, is it appropriate to share patient information with a fellow colleague who does not have direct contact with that patient or have anything to do with that patient's procedure, whatever? And the answer would be no, right? Like, and this does happen. We have people where there's patients that come in, they've done something that is either really interesting, really bizarre, really inappropriate, whatever, and people like to share and show that and laugh about it or just show it as whatever, right? That's inappropriate. Unless you have something to do with that case, you shouldn't be looking at those records, okay? All right. Defamation, disclosure of a confidential information in some way detrimental to the patient. So we have, that comes under, falls under slander and libel, right? In laws today, they usually group them together because it's becoming really hard to determine what is slander and what is libel as far as separating them. Okay, in which we'll go over each one of those separately. But defamation is just if we say something that would be harmful to that patient. It may be unintentional, right? We have unintentional torts, might not mean to be defaming somebody, but you still have the possibility of doing so. So slander, oral defamation, in which someone tells one or more persons an untruth about another. Okay, so just think of slander as spoken, put the S's together. That's how I remember it. Okay, spoken defamation, slander. Now with social media being so prevalent and everything now, when a court looks at, I have a friend who's an attorney in cases like this, and he says they kind of just throw them together as defamation. They don't really split them up with slander and libel anymore. But for the boards, you still need to know the difference between the two. So slander is spoken, okay, defamation. All right, and now that I look at this, I realize it's a mom joke. It's probably not very appropriate. Right? It's dissing on somebody else's mom, which is defamation. Maybe it's completely appropriate. Maybe it represents it the best way. But okay, libel, same thing, just written. Okay, so again, with those new laws, or with the new things that we have with social media being so prevalent, where it's hard to say whether a Twitter comment is written or just spoken and where free speech comes in. When we're talking about healthcare, if you were to get on Facebook and say, oh, I had this really bad trauma today, and it was just really interesting. It was this car wreck that happened on I-15. Well, and you give all these details, and it makes it pretty obvious what the accident was and who was involved, because it talks about one of your state senators being involved in that accident or whatever. Then you could have, you're invading privacy. For one, you shouldn't be commenting on anything that happened at work. But if you're naming people or showing it, it could be considered written defamation, right? Okay. All right. Negligence, unintentional torts. So that whole 3043 course that you all took when you had to do your case studies, for most of you chose unintentional torts that fell under negligence. Okay. This happens in healthcare. These are the most prominent cases in healthcare, where somebody unintentionally hurt somebody. So like imaging the wrong patient or part, or patient has an injury because they fell while they were under our care, something like that. Okay, we have unintentional torts of negligence are the most prevalent in healthcare. Okay, just accidentally hurting somebody, or them having a bad outcome because of something the healthcare provider did. Okay. Okay, so there's 4 elements that have to be proven in order to have an unintentional or negligence to be proven, right? So duty, what should have been done. So they are going to go, if there's a case like this, they're going to be asking for standards of practice. What do we normally do? And they ask expert witnesses. So any of you at any time, as soon as you become certified, you may be called by some attorney someday saying, hey, we want you to be an expert witness in this case that has to, and maybe for one side or the other, where they want to know what your standard of practice is, what you would normally do. Okay, they'll be looking at those ASRT standards and the ARRT standards on what we do for standard of care, as well as like Joint Commission. They look at those things, but then they want expert witnesses too. So they would say, what is your standard of care for transporting a patient in this situation with a head injury or something like that? Okay, so they establish what should have been done, and then if there was a breach of that, so what was done differently than what the standard that everybody considers to be the standard, and then if there was an injury sustained, and then what was the result of that injury, so the cause. Okay, and then that malpractice is usually what ends up coming from negligence. Okay, so they it's the term that we're most familiar with. Okay, questions on that? Okay. All right, here's a term that I used to be able to say, we're not supposed to say that. I guarantee this is on your boards, right? We can't, but I can say that there's a high likelihood that they will ask you the definition of this on the board exam. Okay, res ipsa loquitur. So you need to know this. The thing speaks for itself. Okay, this is the one that, if I think the example I gave you is the patient that I once had that had respiratory issues because he went in for carpal tunnel surgery, he was sick, and he told the anesthesiologist he was sick and he didn't want the surgery, and they said, oh, you'll be fine, we'll give you some medication. He vomited during a surgery, anesthesiologist didn't notice it. He aspirated all of his own vomit, which burnt up his lungs with the stomach acid, and he had to be on oxygen for the rest of his life. Okay, res ipsa loquitur is what gave him his settlement, his lawsuit of hundreds of thousands of dollars, which is still not worth having your lungs burnt up, right? But he won his lawsuit because it spoke for itself that he should not go into surgery for carpal tunnel and come out with burnt lungs, right? They had negligence there. There was malpractice. But res ipsa loquitur is what solidified that. Okay, the thing speaks for itself. Questions? Okay, that happens in a lot of cases too. Like you've heard of surgery cases where somebody's in there for whatever surgery and they end up having a burn on their abdomen or their leg or whatever from the cauterizing machine being left on and then sat down on them, and then it burns through the sterile drape and into the patient. Erica? So that's a risk. So that goes under informed consent. They would have talked to them about that. So Erica's question, for those that are online, asks, what if somebody goes in for a surgery and ends up having cardiac failure? Which happens, right? It's not uncommon for that to happen. That's one of the risks of anesthesia that they would have signed consent about before, so they'd be covered that way. Yeah. So that wouldn't be negligence, right? Would it be negligence or malpractice if they would have been like, oh, their heart's giving out, I guess we're just done, we're not going to do anything. No, they have to try to save their life, right? But if they were to just ignore it, then it would be that. But it is one of those risks with the informed consent. So good question. Okay, respondeat superior. Let the master answer. This is that one that as radiographers, we are responsible for all of our actions. All right. So is the place that employs us. So is the physician in which we are working under. So if you're working in general radiology, it's your radiologist. Even if they are not on site, you are still working under them. Okay, which means they are responsible for everything that you do. If you're in a surgery case, the surgeon is the one that is responsible for you, right? Which kind of explains why they're a little bit tense sometimes, right? Or they're really wanting to make sure that we're doing the right thing because they are responsible. Their malpractice insurance has to cover us as well. Like things can happen where they could be sued as well for things that we're doing. Okay. All right. Moving on to infection control. So again, this used to be 5 of the 30 questions in the patient care section. So regular microorganisms, we all have these on us at all times. We're all touching them right now. They're on everything that we're around, right? Some of those are good. We need some of those. We have normal flora in our body that are microorganisms. Most do not produce disease. However, we may have some that are pathogenic that can cause disease. Okay, so that's what the definition of a pathogenic microorganism is they are capable of causing disease or infection. Is normal flora capable of causing disease or infection? Yeah, if it's in the wrong place, right? Okay, good. Normal gut flora in our intestines, if it gets in another area in the body, it can cause us to be septic, right? If it leaks out of there or goes somewhere different place. If we ingest it orally, it definitely can, right? If it's not already there before. Okay. Medical asepsis. So we remember we got to talk about medical asepsis compared to surgical asepsis. Medical asepsis is, in simple terms, disinfection. Trying to remove the majority of these microorganisms. Okay. By washing our hands. What's the number one way to stop the spread of infection? Washing our hands. What's the number one way, or what's the number one cause of the spread of infection? Non-hand hygiene, right? Poor hand hygiene. Good. Okay. So disinfection isn't just washing our hands. It's just the number one thing that causes it or causes those pathogens to be spread. But it also means wiping down the bucket, wiping down our areas, cleaning everything, having clean laundry. Some sites, I've been told, request their techs to use the same sheet for every patient, as long as it's not visibly soiled. That is against everything that we've learned and studied and know. And if Joint Commission knew that, they would get a huge fine. Okay. You use clean sheets for every patient. Okay. Now, can you have a pillow with a pillowcase with a clean sheet over the top of that and having the patients lay over that again? Yeah, you're protecting it with a new sheet, a barrier, right? Can you have them no sheet at all and just have a hard table? Yeah, as long as you wipe it before and after every patient, right? Okay. So if they're telling you to use the same sheet for every patient, they're also telling you not to ever worry about wiping down your bucket or anything else, which you should be doing between every single patient, right? Okay. Does it happen? Do people wipe down the bucket after every patient? There's a lot of people that don't, right? Okay. But we want to remember that we want that done for us, so we expect to do it for everybody else. Okay, surgical asepsis, same thing as sterilization. So we're removing all those microorganisms and their spores. So the complete removal, not just 98 or 99% of them, but the complete removal of all of them. All right. In your textbook for patient care, it told you about different types of sterilization. You don't need to know that for your boards. You just need to know that surgical asepsis and sterilization gets rid of it. Okay. You don't need to know about an autoclave or there's chemical versus steam and all that stuff. Just know sterilization is surgical asepsis. Okay. Surgical asepsis has sterilization, and then it also covers our sterile technique. Knowing how to wear sterile gloves and a sterile gown and not contaminating a sterile tray, being able to set up that sterile tray, right? As far as them asking you in-depth questions like we did in the patient care class, not quite as likely, but remember if they do, they ask you about opening a sterile packet that's going to be your sterile tray, which is really common for us as radiographers to do. When you open it, which way do you open it first? Yes, up and away from us, right? So or back and away, however you want to describe it. But so that first tab goes away from us. So the rest of the tray is still being covered. And the last one we pull towards us because then it stays sterile. We're not contaminating it by leaning over it. That's the whole key, is not to lean over it, right? Okay. When we are doing prepping a patient for arthrograms or venipuncture, even anything like that, if we are using iodine-based chemicals to do that, what is the procedure for it? Say we're doing a urinary catheter, because we use iodine for that every time. What do?
You start in the center and work your way out.
Great, thank you. Yes, thanks, I think that was Jeff. Start in the center, work your way out and making circular motions around the gland, if we're doing it on a male, right? Around the urethra in both cases. If we're talking about, same thing if you're talking about placing a urinary catheter, or if you're just doing a lumbar puncture per se. Start in the center, work your way out. Never going over the same place twice, okay? Discarding that, getting another sponge or cotton ball, whatever you have, and start in the center, work your way out, okay? If you are using ChloroPrep, the orange stuff, right? Not the brown iodine grasshopper spit, but the ChloroPrep. If you're using that one, what's the protocol for that? Scrub vigorously for how long? A minute? 30 seconds is what it may be a minute. They won't, I think it's 30 seconds. It was 30 seconds, covering each area for a total of 30 seconds. So when you see them in the OR and they're scrubbing forever on an entire leg, that's because they're supposed to do 30 seconds for each area, right? So that's why they're scrubbing for like 3-4 minutes, the whole entire leg, if they're going back and forth trying to kill that, because the friction with that is removing things and also killing bacteria just from the friction. Okay. Nosocomial infection, also known as hospital-acquired infection. The board still has it listed as nosocomial infection. Okay. Any infection that we acquire in the healthcare setting. That's why they don't like the hospital-acquired, because it can be it could be home health, it could be anything that is delivering healthcare to a patient. We can spread infection that way. So you get an infection from that, that's considered a nosocomial infection. What is it called when we know exactly what caused the infection? Anybody remember that word? Starts with an I. Iatrogenic nosocomial infection. Yeah. Somebody comes in for a lumbar puncture and they end up with and meningitis from that procedure. We can say, well, it's because of that. That's an iatrogenic nosocomial infection. We give them a urinary catheter and they end up with a UTI because of that. That's an iatrogenic nosocomial infection. UTIs from catheters are always iatrogenic nosocomial infections. Can you get a UTI that's not an iatrogenic nosocomial infection? Yeah, people can develop UTIs. Go swimming in a lake or something and get a UTI from it, right? Okay. All right. Methods of transmission. Remember, there's two main categories: direct and indirect. Direct contact is when sexual intercourse, all those intimacy things, right? Kissing, or when we directly touch the infected person. Okay. Direct contact. Indirect has a lot of different ones. It could be that we're indirectly touching the mouse, right? From the computer table, the chairs you're sitting in, whatever. All those fomites. That's what a fomite is. It's just an inanimate object that falls under indirect contact. Okay. Droplet. Sorry, there's direct for you. Okay. Okay. It's pretty, huh? What kind of infection is this? Anybody know? Herpes? Is that what herpes looks like? I don't know either. We'll call it herpes today. All right, indirect, touching an inanimate object, so like sharing because of the hand thing. Yeah, that is gross and creepy, huh? Yeah. So yeah, sharing a drink with somebody or touching a doorknob, any of that falls under indirect. Okay. It's sad that we think of a hand like, I mean, that's just a hardworking guy. That's his hand, right? And we're saying it's dirty and gross. Okay, droplet. This is what it really looks like when all of us sneeze or cough, right? Yeah. Okay, droplet. It's when I get to use those words that you hate. Right?
Moist.
Wet, moist secretions. Yeah.
Out at 100 miles per hour.
Does it?
That's what I read.
I'm gonna share that back with my kids.
Yeah,
So when somebody's grossed out, be like, don't be grossed out. It's like this record speed. It's 100 miles an hour. Just all that much faster that it's contacting you and getting you sick, right? Okay, yes, droplet is when they are those wet, moist secretions. Is it only sneezing or coughing? No, tears, the tear duct is considered that, can be droplet, right? Can blood be droplet contact? Yeah. Something happened in the OR, they're getting way crazy with the saw and it throws blood everywhere, right? Like, anybody ever been hit? You're laughing. Have you been hit with blood in the OR? I've been hit with blood in the OR, right? That's right, pounding on things. It's not as delicate as we think it is. Okay, vehicle. So food, water, anything that we can ingest or inject, basically, right? It is the water or the food isn't the vehicle, or sorry, they are the vehicle. It's not the disease, it's just something on there. So the easiest one is the E. coli on spinach, because it keeps happening like every 10, 15 years. We have an E. coli breakout on spinach or lettuce or something like that, right? One of them was where the pigs were in the same field that the spinach was growing and they got feces on it and wasn't cleaned properly, and then people were ingesting that, okay, getting E. coli from the vehicle. Okay. Blood transfusions. The blood itself is the vehicle that the disease is being carried. AIDS used to be a problem with that. Before they were able to detect AIDS, people were getting blood transfusions from people that had already contacted AIDS, and they end up getting it that way. Okay. Drugs, sharing a needle. The vehicle, the needle is the vehicle. Okay. With the germ, the pathogen on the needle. Okay. Airborne. I guess I don't have a cool picture for airborne. Sorry. Dried particles in air. So when those wet, moist secretions dry up and they're floating around, or it could just be a dried piece of fecal material on our sheet that we shake off or throw across the room, right? Yeah, exactly. I was famous for doing that. I'd always try to do a 3-point shot. And then I started teaching this and like, ew, gross, right? I don't want that. Okay. So yes, walk it over to the bin rather than throwing it, because those dust particles you see, now everybody will see it, because we always have dust particles. If you look at the projector up there, you'll see things floating in it. That is airborne contact. Okay. All right. Makes everybody a germaphobe when we talk about these. Oh, why are you not going to? We're done. That's not the last one, is it? No. Could be. Okay. Vectors. Again, anything that can bite or scratch, right, and carry disease. So I told you all the story, I think, of my student who had a pet cat, right? House cat, never left her house, but it clawed her middle finger. And a couple days later, it swelled up really bad. It swelled up so bad that it was splitting open. And they thought they were going to have to amputate it because it was infected so bad from her cat's claw, right? So that's an example of a vector carrying it. Mosquitoes are a good example because of West Nile virus and malaria and those things that they carry. But yeah, anything that can bite or scratch you. Bats carrying rabies, other animals carrying rabies. Okay. Questions on vectors? Okay. Can a human be a vector? A human being? Yeah. If they bite you or scratch you and they have something infected, definitely. Okay, and fomites, just inanimate objects. Anybody know what this is? I mean, it says phone on it. Yeah.
Who here is actually using it?
This is how I'd get my mom to come pick me up from school after school when I was in junior high, and it only cost $0.25. For some of you, it was 35 cents.
Call collect.
I call collect all the time. I say, "Mom, it's time for you to come get me."
Yep.
And then I heard, and then they'd be like, "You have a collect call from Mom. It's time for you to come get me." Yes, we did that all the time because I didn't have a quarter, right? Okay. All right. Oh, I forgot that I had this in here. I was going to talk about it anyway. All right. Positive contrast versus negative contrast agents. So when we're talking about contrast media, all right. Again, you're going to have board questions, or the possibility of having board questions that are going to ask you about contrast media and radiographic contrast. Tissue density, radiographic density. We have to separate those, and they will be specific so that you'll know what they're talking about in your boards, okay? So let's go over this. Positive contrast agents increase tissue density. Okay, so they're talking about barium, isobute, gastrographin, gastrobute, any of those things that those non-ionic and ionic contrast agents, medias, that increase tissue density. So when we have somebody drink barium, it increases that tissue density. It's coating it. It's making it harder for X-rays to get through. It's making it more dense. All right. Which, if we are increasing tissue density, we are making them more radio opaque, meaning X-rays cannot get through them as easily. Can they still get through them? Some of them, yes. Okay, and depending on our technique, but it makes it more radio opaque, okay? Therefore, the x-rays cannot get through the body to reach our IR, which that decreases radiographic density. Radiographic density is the overall blackness of our image, right? Everybody good? Okay, negative contrast is the opposite. Air and CO2 are the two that we use. We use air more than anything. We do it every time we take a chest x-ray. Big breath in, filling the lungs with air, stretching that tissue out. Remember, we use the analogy of the balloon. You have a balloon that's colored, it's deflated, it's really dark. As soon as you start blowing it up, it gets bigger and stretched out, and you can see through it, makes it more translucent, right? So negative contrast media makes tissue, decreases tissue density, making it radiolucent or more radiolucent. X-rays can get through it, radiolucent, which means they can hit this image receptor and increases radiographic density. So if we have a decrease in tissue density, we're going to increase radiographic density. And it's not just about the thickness of the part, right? Your chest, the thoracic cavity is just as thick as the abdomen, but it's not as dense. There's not as much junk in there, right? So we have all this air. Okay, so it's about the density, not necessarily thickness. Okay, we good about that? Does everybody remember what we mean by radiographic contrast? Radiographic contrast is the difference in the whites and blacks, right? What is high contrast? What's that? Just black and white, no gray tones, right? So what's long scale contrast then? All kinds of gray tones, right? Okay, short scale is just the extreme high contrast, right? Okay. All right, we talked about this already, but we'll go over it really quick. Non-ionic contrast is the one that is chosen by radiologists over ionic contrast because it is safer, because it is closer to our body's osmolarity. Which makes it less likely for an allergic reaction. Can we still have an allergic reaction with non-ionic contrast? Yes. Can we have an allergic reaction on a patient that's already had contrast previously? Yes. Can we have it on their first time receiving contrast? Yes. Okay. But I thought you had to be exposed to something in order to have a reaction to it, for your body to create an antigen. Is that true? Yes, that is true. However, there's substances that are in the contrast that they may have been exposed to somewhere else in their environment, ingested it some other way or whatever. So they may have already had that, so they could still have a reaction to it. Okay. So the point is, any patient at any time could have a contrast. So whenever we are dealing with contrast, possible boards question, we never leave the patient unattended, right? Never. Just like we never leave them unattended if they're on the table. They could fall off. Even our coherent, healthy patients should not leave them alone on the table without, at least where we can't see them, right? We should go. Do we do that? Do people do that? Yeah, you're behind the console and you have a question, you run and grab somebody and the patient's still on the table, right? We're not supposed to though. That could, if they rolled off or whatever without us being supervised, that could cause you a negligence case.
I have a question.
Yes.
What about like during small bowel polyp?
You're watching them forever. And you always have
You have to stay. We don't.
technically, if they're laying on the, if they're on the table, we're supposed to. Does it make sense to let them?
Put them in a chair.
They're supposedly safe. Yeah, I know.
Doesn't take them on.
I know. So the best thing to do if they're in small bowel fall through and they're supposed to just, if they're supposed to just lay there, the best thing is to lower the table all the way down, right? To the ground. Even if your table won't work unless it's up, like a lot of them do, you have to have it up before it'll start working. You lower it all the way down in between your images. Okay. All right. Okay. Needle gauge. I added this, I think, last year because students were having this on their LPT stuff, yeah. And so I was worried that it might be on this board as well. So needle gauge, remember, the bigger the number, the what? Smaller the needle, the diameter, not the length. Length is completely different, right? But the diameter of the needle. Okay, so bigger the number, when we talk about gauge, the smaller it is. Okay, when we talk about, I think it might be the next one then, catheters, yes, we talk about French. Sizes in French, the bigger the number, the bigger the diameter. Okay, so 14 French is smaller than a 16 French catheter in diameter. Again, has nothing to do with length. We can have different lengths. It's just the diameter. How many cc's are in a compared to an ml? If you have 1 cc, how many mLs is that? It's the same, right? Yes, okay. Questions? I just feel like a race. No, I usually go over. Any questions on them stories? I didn't tell enough stories. I guess maybe I've just said this too many times and I talk fast. I've been
Can
doing.
you, sorry, review like mild, moderate, severe reactions?
I don't have them on here, but yeah, they could ask. I think what they would ask you for sure is, so we know that sneezing and itchy feeling and that overall overwhelming warm feeling is considered mild, right? And you can go from mild to moderate to severe within a split second. Like you can go from mild to immediate, like everybody reacts differently, right? So if we go really fast, that's what they would ask you, I would assume is considered that way. Okay. Even hives turns into moderate, right? Depending on the extent of those hives. Erica, did you have a question?
Yeah, the questions that you're asking, did you just go off of like on the red, that you can say it out on these?
Sorry, say that louder. What?
Sorry, you know, like on the ASMT, it gives you all the questions that takes care of what you need to know. Is that what we did from over?
Yes.
Okay.
So that's why I chose these, is because it was every topic that was on the board content.
On that, okay.
Yeah. Yep. For the section that I was assigned, somebody today will cover the rest of them. If they weren't, it might be like, oh, that seems like a patient care thing, but if it was in somebody else's section, they will cover it instead. Yeah.
That's it.
Yeah.
You just give examples for like moderate reactions, I feel like I have a pretty good idea of how to.
Well, okay, so the thing is to remember that even those mild ones can become moderate. It just depends on the extent. So like somebody can start saying, oh, I'm feeling a little red and flushed. And when that turns into hives, now it's a moderate, right? And if they come into big hives, then it's a severe reaction.
So vomiting, I feel like
Vomiting they list in the book is, and that's, I don't think the board's is gonna get that precise with you, because like in the patient care book that we use, it says that vomiting can be a mild reaction, right? But in another patient care book, it considers it a moderate reaction.
Right.
So that's why the boards, they're gonna be more about, hey, patient's having a reaction, what do you do? What is the first thing we do if somebody has a reaction? Stop the procedure and call for help, right? Are we able to administer contrast in an IV without a physician being right there next to us? Yes, definitely. We do IVPs. We don't do them very much anymore, but we used to do them all the time. We just have to have a physician available in-house, right? Doesn't mean it has to be the radiologist, it just has to be a physician if you're doing it. Okay. All right, so stop, call go through your code protocols for that. Okay. Other questions? It depends. See that they're not going to ask you a question like that either. They're just curious. I know. I'm just clarifying. I think that's good. So it depends on your hospital's protocol. Where I was at, we had the code button on the wall that did everything for the first 5 years that I was there. And then they're like, you know what? We want to call different codes. So yes, if you're in our imaging room, then push the button and they'll just figure it out. But if you're like able to get to the phone and call the code, then say, hey, code cardiac arrest or code blue or whatever. Yeah. So it depends on what your hospital has. And even when you talk about like everybody uses code blue is okay, that something bad's going down, right? But some of the other colors like code silver and pink and all that, they vary at different sites. So the boards will never ask you those questions that would be variable. Yeah. No, I think that's good.
Just call.
For me, I just call. So I told you the story of the 25-year-old that was healthy, athletic, come in and he had a vasovagal response. We all remember what vasovagal response is, right? Where you just pass out for whatever reason. Mainly it's a mental thing. You're thinking about something too much and it makes you pass out, right? You can get lightheadedness and a vasovagal response from other things, but that's the main thing. He had a vasovagal response because he'd never been in a healthcare setting before, and he was just overwhelmed by his environment, is what he told me afterwards. He started to pass out. I didn't know what was going on with him. They had more protocols for other things, even if it was just pass out. Luckily, I had a student with me. I'm like, hit the code button. And he woke up before anybody got there. And I remember the radiologist coming in and like, well, it doesn't look like a code to me. He's talking to you. And I'm like, yeah, you freaking idiot. He was passed out though, right? Like, I didn't call because I wanted attention. So it was like, it's one of the last things I want to have to deal with, but it's just call it and then figure it out after. It's better to be over prepared, right? Or over call something than to do that. Now, in most cases, when you need security, you can call for security. I did work with a tech that just called the police one time. He called 911 because one of the patients was threatening him. So instead of calling security at the hospital, he called 911. Why would you do that? Because the patient literally said, I don't like you. I'm going to punch you in the face if you get too close to me. So instead of just saying, okay, I'm going to step back and call security, he calls 911. You don't need to do that. Okay. He got in a lot of trouble for that. Sorry.
So they kind of gone over what two questions. A lot on that is you can't tell that it's left free of the best. Is that kind of
Rad Tech Boot Camp will what?
Rad Tech Boot Camp will have us like split the three best actors.
Oh yeah. The boards doesn't do that crap. Okay. Yeah. You know how even on my crappy patient care test, it would say select A and B or B and C and all that. It will not do that on the boards. Yeah, they will not say what are the best ones. It'll say you will have true or false, or it is A, B, C, or D. Like it'll be one option.
1, 2, 1, 2, 3, 1, 2, 3, 4.
From what I was told by my contact there, they don't have that anymore. Straight forward. One answer. I will try to double check before I leave. How's that? But that's what they told me. So who's taking the limited license? Did they have those ones where you had to select multiple choices?
2, 3, 1, 2.
They did do that.
That's a state test. Yeah,
No, it's not a state test. You're limited is from the ART. You just signed up for it for the state.
That's not how they explain it.
You have to shut up. Yeah, you have to. Yeah.
Okay, well, I don't know. We'll figure it out, okay? It'll tell you in that pamphlet. It should tell you what the options of questions are. No, because we're not done. You're still asking questions, but thank you for reminding me.
About like ages of children and like spoiled behavior, and I get wrong every time. Like preschool, toddlers, school age, like the way that it is that something that's gonna be on?
Again, it'll be more simple in the boards. If they ask you something like that, they'll ask you like, how do you, like, what is a normal communication procedure for like a 4-year-old or a 5-year-old? It'll be like, what, you get down to their level, things like, they'll make it way more cut and dry though than what we're at. Yeah. I guess we probably could. Okay.
Okay. So I'll just have to do it on this thing. Okay, so really quick, it says 2023, don't worry about that.
Can you do screen share?
Screen share. See, I knew I was doing something wrong.
Thank you.
Screen share. Screen share. Can you guys see that?
Yes.
Okay, thanks, Jeff. Okay. ART content specs. You don't have to take a picture of this because you have this at home somewhere on all my courses. So this is your content specs. This is page 5. This is radiation physics, radiobiology. And we're going to cover everything on this page. So let's go. So as you can see, when you look at your test, hopefully you don't see me, it'll say like principles of radiation physics, X-ray production, source of electrons. They're going to ask you a question about your source of electrons. Where are we getting these electrons? Anybody know? No, you're about to graduate.
That's when you push the button, right?
So we boil them off the filament through thermionic emission. And what's that filament made out of? Tungsten. Perfect. Yay. Okay. So X-ray production. We are going to have in our circuitry a milliamp. We're going to step down the voltage for the filament circuit, which steps up the amps, but they're already so low, it's going to be milliamps. And that current of electrons is going to be on a copper wire. Yes, in the front row.
Hey, we're gonna do this really stupid in our second year, but I've been looking at the X-ray tube and everything.
Right.
So the step down is the anode side and step up is the cathode.
No, step
right?
up is the anode side. Step down is the cathode side. When they say step up or step down, they're talking voltage. So whatever it says is voltage, and then it's the opposite for milliamps. Okay. So this is the filament circuit. It's a copper wire. We put current, which is amperage, in that. The electrons go because copper is like the third best conductor. And then it hits the tungsten filament, which is going to resist the flow of electrons. We're going to call that ohms. And that is going to cause thermionic emission. And we're going to boil off the electrons from that filament. Yes. And thus that's thermionic emission. And thus we are going to boil off electrons. They're going to sit there in the little focusing cup until we press the plunger, which the plunger is going to introduce voltage between the cathode and anode. That'll accelerate my negative electrons from the negative cathode to the positive anode, and then we'll get X-ray production. So cathode is negatively charged. I just boiled off electrons. They're not going to like to sit there. So as soon as I apply a voltage, which means I have a potential difference between cathode and anode, we're going to have a flow of electrons. The higher my voltage, kVp, the more kinetic energy they're going to accelerate with, which is going to be more energetic photons that I'm going to produce off of brimstone. Okay. What is voltage? Saying that I have not too many electrons here and I have a lot here. We have a conservation of energy says that's not correct. So we're going to have equalization, which means we're going to have flow of electrons from the cathode to the anode. And this is my kinetic energy. This is higher kVp, higher kinetic energy of the electrons, meaning they're going to slow down or have more intense brimstone, and thus my photons are going to be more energetic. Tungsten is Z74. Okay. So what we're going to do is we're going to have those electrons are going to interact with the anode, which is Z74, and thus it has a lot of electrons, 74, and has a lot of protons, 74. And so it's going to come in, those electrons are going to come in, and they're going to slow down and turn, and conservation of energy says that's not possible unless you give me something, which is our X-ray photon. So as those electrons impact the anode target, they're not really hitting it per se. They're just interacting with it. It's a bunch of trees, and we're a little electron coming in, and they're going to get attracted to the 74 protons and slow down. Most of the energy is because we're going to have kind of a low energy electrons that are going to interact with the atoms of the tungsten. So we're going to produce mostly heat through infrared and a lot of light. Only 1% X-ray photons, enough energy to be in an X-ray photon. Here's our brimstone. What's the real interaction? Well, everything below 69.5 kVp is just going to be slowing down and turning. The more I slow down, the harder I break, the more energetic the photon I give off. It's a difference in energy. As they come in, they're going to be attracted to the 74 protons in the nucleus of the tungsten. They're not actually going to be ionizing the atom because most of them are not strong enough because they're below 69.5 keV. And thus, the more they get close and break Brimstollen and turn, the more energetic the photon coming off because it's a transfer of energy. We can do this different ways. We could do an electron gun, just shoot electrons, have them go past the anode and slow down. That's going to give me off photons too. So anytime an electron slows down, it's going to give off a photon. Like we said earlier, most of the time it's going to be heat or light, but at a certain energy in the thousands, 10,000 or so, we're going to have X-ray photons. We're going to call these electrons going from cathode to anode filament electrons. So note that. They're going to be called filament electrons. Remember, this X-ray production is electrons and protons and electrons. It's not, there's no photon until Brimstollen happens. Then we get photon off. So electrons going from the filament, from the cathode filament to the anode or filament electrons, they're going to interact with the tungsten atom, which has electrons and protons. And because of that interaction, that slowing down, we will have X-ray photons be produced. So for example, a filament electron enters an atom with 100 keV. That means maybe I have 100 kVp on my setting. Energy as it passes the nucleus leaves with 30 keV of energy. The Brim's photon produced is 70 kilo electron volts. Just a transfer of energy. Everything has to be the same. Conservation of energy says there is no making, we can't make energy, we can't lose energy. It's just a change in energy. Then at 69.5 kilo electron volts, we start having characteristic interactions. That is because the inner shell electron, the K shell, is exactly 69.5 kilo electron volts binding energy. Once that happens, now my electron, if it is 69.5 kilo electron volts or above, can actually knock this electron out of its shell.
We have to know the binding energy of like.
Yes.
All of them.
No.
Just.
K and L would be really nice to know.
L2.
L2, just in case. Okay. Only for tungsten. Remember, this is only for tungsten. This same thing happens when we do the body, but we're using photons knocking off like calcium's K shell, which we really don't need to know that. But this, 12.1. So we have to know this because this is going to produce what we call discrete energy photons. It's not a polyenergetic beam anymore. Once this happens, an L shell jumps into the K shell, it's going to give me off a 57.4 kilo electron volt photon because it's the difference in the binding energies. It does not always have to happen that way. I could have M shell jump into K shell. So when we look at those graphs, you're going to see this beautiful polyenergetic graph, and you got these little peaks. One at 57.4, one that's probably 68 or so, because things can jump around. Just one question. That's all you need to answer. That's how it plays it out. One good question on characteristic. What are they going to ask? They're going to ask, what is a characteristic photon? And that's when I eject the K shell electron, and now the L shell jumps into the K shell, gives off a 57.4 kilo electron volt photon. M shell into L shell. Don't really care because now we're getting down into low energy or lower energy photons. But anything can happen. They're just not going to ask you all those questions. Just have to know the concept. So characteristic interactions, it is my filament electron knocking off a K shell electron of the tungsten atom. So that's why we know it's specifically 69.4 or 69.5. Okay. Has to be greater than the orbital electron, otherwise it doesn't happen. Nothing happens. Then we have a cascade. L shell to K shell gives off a photon. M shell to L shell gives off a photon. How many shells do we have in tungsten? If we have 8 shells, because it's a huge atom, 74 electrons. We'll look into that. Here it is. 1, 2, 3, 6. If you want to memorize them, there they are. K shell 69.5, L shell 12.1, M shell 2.82. Yes. At least my part. So does that make sense? If I knock out the 69.5, the 12.1 jumps in, 69.5 minus 12.1, that's the photon it has to give off to make that energy transfer. Okay. So what if M shell jumps into K shell, or it goes into L shell? Well, that's what 12.1 minus 2.82. That's 10 kilo electron volts. Now we're into coherent interactions. Really, that's not a viable X-ray. We're going to filter that one out. So a characteristic photon is going to be named after the shell being filled in each case. That'll be a K shell photon. Don't know if you really need to know that.
Sorry to interrupt, are coherent less than 20?
Less than 10 kilo electron volts. Yeah. And it's not always that way. We're going to have Compton scatter too, but coherent, remember, doesn't do anything. It doesn't ionize. So it's radiationless. So what are we going to have with our X-ray interactions? And this is how you answer all your questions. Okay, we know we have to know how to produce X-rays. That's fine. Cathode, anode, MAS, KVP, all that. That should be something you are set in. That's production. Once we get into all the interactions of matter, we're going to have coherent under 10 kilo electron volts. It does impart energy into the atom, but the atom doesn't ionize any electrons. The atom just kicks it out in a different direction. It is scatter, but it's below 10 kilo electron volts. So no harm, no foul. Not really a dose. It's more heat or light. Then we have Compton scattering, which is interacting with an outer shell electron, at least in X-ray speak, which is going to ionize the atom, making it reactive, and it changes the direction. And as we saw with even tungsten, which we don't have tungsten in our body, that's D74. Highest thing we have in our body really is the like 20 maybe. Okay, calcium. So the binding energy is going to be very low. So if I'm coming in with Compton scattering, if I'm coming in with an X-ray photon that's at 30 keV and it ejects a K shell photon that's maybe at 5 keV, I have a, very 25 keV X-ray photon going in a different direction. It has plenty of energy to do other things. So it's going to do thousands of interactions. Photoelectric effect, number one question on that is, what happened to my photon? It gets absorbed, it's done. It gave up all of its energy to knock off that K shell. It really has to be exactly that energy or slightly above. It can't be too far above, and it definitely cannot be below. It knocks it off, my X-ray photon's gone, and my electrons called a photoelectric photon, or electron, and it's off doing something else. And we start the cascade again, right? Just like production. I knock the K shell off, now L shell jumps in the K shell, M shell, which still leaves the outer shell electron open, which makes it reactive. That's why ionization is so bad. Now I have a reactive atom who is going to attach to something else, which is usually going to be oxygen. We do have pair production, but that's at higher. That's like 10, over 1,022 million electron volts. That's only in therapy. And then photo disintegration, that's at 10 million electron volts. We don't deal with those yet. You will have questions on the test on that though. Yes.
With photoelectric effect, it happens in an inner shell, right? Does it happen?
Yes.
The K shell, or could it be an L shell?
It could be
Any
any,
other
it
shells.
could be, so Compton and photoelectric could be any shell, both of them. But we only talk K shell and outer shell.
Just to simplify.
Simplify, yeah, because otherwise we're going to get all messed up. Photoelectric effect, we did knock off the inner shell. And the reason we knock off the inner shell, why that's so prevalent, is because that has a high binding energy. Remember, we're not dealing with tungsten, we're dealing with calcium Z20, oxygen Z8, nitrogen Z7. Yes, and tungsten is very specific. In the body, we don't know what it's going to interact with. But most of our, 90 kVp, which we don't use for hardly anything except for abdomen and pelvis, our binding energy, or our mean energy is about 30 kV. If I'm doing a wrist or hand at 65 or 60, my polyenergetic beam is at 20. So now I'm matching up very good with calcium, stuff like that. Which, if you look at an X-ray, what's getting photoelectric absorption? The bone. The fat's not. It's the bone. If I'm doing fluoro, 90 kVp, then it's going to match up really good with the 30 kilo electron volt binding energy of barium and iodine. That's why it's white, because we're getting full electric absorption. So Now my photoelectron goes off and lives a great day, and we start to cascade. And once again, what are we dealing with? Calcium Z20, nitrogen Z7, oxygen Z8, carbon Z6, hydrogen Z1. So tiny little, tiny atoms with very little binding energy. Okay? But photoelectric absorption is the only one that actually cares about the Z number. Compton doesn't care about the Z number. Coherent doesn't care about the Z number, and transmission doesn't care about the Z number. Photoelectric does. So that's something you need to know. Probability of interaction depends on the energy of the incident photon. It has to be exactly that binding energy or slightly above it. The atomic number, because we're dealing with an exact binding energy of the K or L shell. Incident photon energy. And of course, the thing on the bottom, who knows what that says? So we should think about that someday. I'm not gonna catch it. You don't have to know about the third power. Compton scatter. What happens to my X-ray photon once it interacts with the atom? It scatters. It's Compton scatter. It doesn't get absorbed. It loses very little energy because most of our atoms in our body have very little binding energy for the outer shell, called the valence shell electron. So it's going to go off and live a wonderful life and maybe exit the patient, come after me, or do 1,000 or 1,000,000 different interactions till it gets photoelectric absorption. Is there a cascade? No. Could there be? Yes. If I knocked out this shell, still going to do the same thing. Maybe this jumps in here, but what's that going to produce? Heat or light. It's too little of energy to be an X-ray or to be anything that's really that bad. Compton. Anybody have problems with Compton? Okay. And it keeps going. What's the main reason we don't like Compton? Remember, if you get a question on anything about interaction with the body, we only have a couple choices. We have transmission, nothing happened. We have photoelectric absorption, my photon's gone. And now I have cascade, which really doesn't affect much. And I have Compton scatter. So any question you get, just think, which one is it? It's got to be one of those three. There's nothing else. There's no other mystery in the body. That's what happens with X-rays. Transmission, photoelectric absorption, or Compton scatter. What's the number one thing it does? It impacts my image receptor and gives me misinformation, scatter. It didn't come from someplace where it's a known entity. So it gives me fog. What's that do to my image? It reduces contrast. That's the answer to everything. This I've been researching for several weeks because I have 5 different books that tell me 5 different answers. And any of you that went out through our LPT program would know that there's a different answer in there. So this is exactly what it is. As KVP increases, Compton scatter increases. It's going to have more energy, more things to do. It's going to hit more atoms. Go, go, go. And it is about energy and atoms. If I have 2 atoms in a bowl, Compton scatter, it's only going to have a chance of 2. If I have 1 billion, it's going to have a chance of doing more interactions. So as I increase KVP, Compton scatter increases. As MAS increases, of course, more photons, more Compton scatter. As tissue thickness increases, I have more atoms to interact with. Compton scatter increases. As collimation decreases, less.
Node size increases.
Gosh, see, I always get that wrong.
I always.
But always think about that. Look, if you get this question, think about it 3 times and then come back to it because I get confused. So field size increases, Compton scatter increases. Field size decreases, Compton scatter decreases. Yes, I hate that. Don't go anywhere. Ready? I'll put it on whatever. You'll have it somewhere. This is all logic. Do not be illogical when you're taking tests. Everything should make sense. Yeah. You should be an MRI tech. So it's gonna get really wacky. Coherent scatter below 10 kilo electron volts. What happened to my X-ray photon? It changed directions. Did it change energy? No. Did it ionize the atom? No. This is pretty much just heat and light. Okay. To our radiation units, SI units. We're
Yes.
only gonna use SI units. They will not ask you anything that's not SI. Believe it or not, time is SI, seconds is SI, okay? So, exposure, I plunged my plunger, X-rays came out of the tube, it's in the air, it's air kerma. That's exposure, coulombs per kilogram. They might ask you air kerma, but that's what it is, air kerma, okay? Kinetic energy in the air. So if they do air kerma, it's gonna be great, but don't worry about it, it's coulombs per kilogram, because this is X-ray, okay? Once the X-rays hit the person and put the kinetic energy into the person, that's all they're gonna say, that's it. There's no dose or anything, there's no biological damage, it's just dose. That is going to be in grays, yes, ma'am.
So the air current and X-ray is coulombs per kilogram? Or what is it?
Well, exposure is coulombs per kilogram.
Yeah.
They are slowly trying to switch over to air current, kinetic energy in the air, which is going to be a gray. But it's always gonna be a GY with a little A on the bottom, that's air. If it says T, then it's tissue. Okay, so
Because I feel like the rent that it was. coulombs per kilogram.
it's always coulombs per kilogram because they don't have a real SI unit. That's not really an SI unit, it's just a way of saying it, but that's what they're gonna use.
Okay, so on
Okay.
the test, it's gray.
No,
Okay.
they won't have both. They'll either have this or this. This is only air current. This is exposure coulombs per kilogram. Okay. Once we have dose into the patient, kinetic energy in the patient, we're gonna call it a gray. That's gonna be absorbed dose. And then once we know what damage, or we'll start calculating damage or protection, we're gonna switch it over to sievert. Okay, so gray is just the dose, sievert is the damage. Now, a sievert dose equivalent is going to be, we're gonna have to calculate in what the radiation source was. And, you know, write this down, out of all the radiation sources that we're gonna have, which is gonna be gamma, X-ray, beta ray, and alpha ray, only one has a different weighting factor, and that is going to be alpha. That's 20, yeah, 20, everything else is 1, okay?
Store dose is the dose, and then damage is just.
Yeah, which dose equivalent is what was the source of the radiation, was it alpha, beta, whatever. Effective dose is the end all dose, which is now I add in not only the absorbed dose, but the radiation source and weighting factor of that and the tissue weighting factor. All right, it hurts, I know. Okay, real quick, we have these 3 things. I'll probably go quick because I'm behind. So you got it, you're fine. We can always do a Zoom call later. Okay, so 3 things that they want you to know for radiobiology. Linear energy transfer, it's exactly what it says. How did the energy get transferred in a linear fashion into tissue? How far did it go? This could be with beta radiation, alpha radiation, gamma radiation, or X-ray radiation. What is the effectiveness of that radiation at killing things like cells? Is it really effective or is it kind of wimpy? And then oxygen enhancement ratio. Does it really matter if you have oxygen? Yeah. So these are all what they use in radiation therapy. They're very, very efficient at killing things. So we use it to know that what if I'm not trying to kill someone or kill something, then I worry about oxygen, I worry about linear energy transfer, and I worry about relative biological effectiveness of the radiation, which X-rays do not have that good of effectiveness. It's not a known effective killer, okay?
They use shrink them, but not.
No, they'll use like gamma rays. Because remember, well, we'll get into it. If we look at this,
Sorry.
if we look at this, we're going to be talking 250 kilo electron volts. That's the original radiation oncology dose was 250. We don't get close to that, right? Okay. Linear energy transfer, the average energy deposited per unit length of track. It's going to be interacting, unless it transmits all the way through, it's going to be interacting over and over and over again in a linear fashion until it stops. And that's going to be called photoelectric absorption. It's finally going to get absorbed. We assess it for tissue damage from ionizing radiation. This is the key. We don't care about anything until it's ionizing. Once we start ionizing, especially with Compton scatter, there's a reactive atom. There's a reactive atom because I keep knocking off the valence shell, or at least somehow, even photoelectric absorption means that my valence shell is going to be devoid of an electron, which means it's reactive now. Okay. Low LET, high LET. This is very important. low LT, electromagnetic radiation, beta radiation. High LET, alpha particles, don't worry about any of these. Alpha particles is 2 protons, 2 neutrons. It's a helium atom without electrons. Can't penetrate very far, but it can wreak havoc once it's in there because it's big and bad. Okay. And alpha particles is radon. That's why we're worried about radon. Relative biological effectiveness. How effective is the radiation we're going to give to this person compared to 250 kilo electron volt X-rays? So let's try it with 250 kilo electron volt X-rays, and let's try our test radiation. Which one's better? It's just a calculation. It's a ratio. Okay. It's effectiveness, biological effectiveness. So my dosing grays, notice a little T, that's my tissue, it's not air kerma. From 250 kVp X-rays compared to my test radiation.
We'll need that, we'll need to know that.
You'll need to know that calculation, yes.
Okay, hold on, do not touch anything.
Oh my gosh. I have to go fast. This is pizza's coming.
Take a picture. Just take a picture.
Take a picture or call me. I'll put it on the web. Okay. There's a few caveats to OER, oxygen enhancement. This is what radiation oncologists. Why is oxygen so important? Well, one, we are mostly oxygen. Okay, that is the #1 element we have. Why? Because we're H2O. One. Okay, oxygen is Z8. Not that you really need to know that. But when we're talking about our radiation source trying to kill something or doing damage, I need to know if it's oxygen or not. And the reason why is because we have indirect action and direct action. Indirect action is radiolysis. We are going to damage the H2O, knock off an electron, and usually what happens is another oxygen jumps in, that's H2O2, which is hydrogen peroxide. So it's going to kill the cell in an indirect action, 2 different steps. Mess with the water becomes toxic, cell dies. Direct action is I just wipe out the DNA or the RNA by doing, I split it and it kills the cell. So we need to know what we can do with this, because if it's got oxygen, then I can actually kill it easier because I can do indirect action. I can use a lower dose. So now I can have low LET. Where is it? So with X-rays, gamma rays, they're low LET. It's usually about an OER of 3. And then about 2 gray, which is a lot. That's a lot. That's a lot of X-ray. That's a lot of dose. Then we can get, approximately 2. Here's humans are 65% oxygen, 9.5 hydrogen, and 8.5 carbon. That makes a difference. So most of our cells are oxygenated. Okay. The other caveat to this is if I have high LET, let's say I crank it up and I have alpha particles, or I have gamma rays that are like super high, or proton therapy. Does it really care if there's oxygen in there? No, because it's going to do direct action. So the OER kind of gets off the table. It's only really used for low LET, not high LET. High LET just comes and wipes out the DNA, and who cares? So we're not doing that, poisoning the cell and then killing it. So here's a calculation for that. Does the tumor have oxygen compared to what if it doesn't have oxygen? That's going to be for the radiation oncologist to know what kind of radiation to use. And it's all about radiolysis for low LET, indirect effect compared to high LET where it can wipe out the DNA. Cell survival curves, as you can see, low LET, yeah, it can handle it, it can handle it until it gets too much, then it starts dying. High LET, you're killing it right away. So our bodies are really used to low LET. I can have a couple hundred X-rays. My body will repair it. Might get cancer later, but right now I'll be fine, okay? What are radiosensitive cells? Anything that's according to Burgonian Trimado. Does it have a long mitotic phase? Does it have high metabolism? Is it undifferentiated? All those are part of Burgonian Trimado.
Are we gonna need to know the tissue weighting factors?
I doubt it. I don't think so.
I think more just the concept of which tissue are more sensitive.
And that's an easy way to think. If I look at my brain, as my parents told me, if I destroy a few brain cells, they're not coming back. If I destroy my muscle cells, they're not coming back. We don't make more of those. My blood cells, lymphocytes, erythrocytes in my bone marrow, they're going like this all the time. And they're always reproducing. So they're very sensitive. Okay. So radiosensitivity and radioresistivity, whatever that is. So how much energy did I impart into it? How damaging was it? Like alpha radiation, okay? Obviously, if my LET increases, I have a better chance of killing things. That's why we don't have uranium in our homes. Oxygen enhancement, I kind of went over that. Oxygen, it's a lot easier to kill something that has oxygen because I can destroy I can mess with the water. Okay, here's Burgonian tremino in one fell swoop. Here we go. Least maturity. If you look at your bone marrow, they start with stem cells, pluripotent cells, and then they get a protein and they say, well, now I'm a red blood cell, or now I'm a lymphocyte, or now I'm a platelet. How about metabolism? We're producing blood cells all the time. High metabolism, not differentiated, and long mitotic phases. We look at the mitosis. We have GAP1, we have synthesis, GAP1, GAP2, mitosis. So GAP2 and mitosis are the most radiosensitive parts. Synthesis is the least sensitive part of the mitotic phase. Radiation effects are more pronounced. We can actually hurt things more if the cell is the least mature.
And then what's the word?
Oh,
Oh, sorry, I just wanted to make sure it wasn't part of something.
but yeah, if you know those four, then you know everything about Burgonian tremino. Nothing else is really, there's not much else to it. You do need to know this. I think probably Taylor's going over this with you, but just get this out of your book, have it in your little study guide. Once you've done it about 100 times, you'll memorize it, exactly what we need for everything, because they will ask you those questions. We already went over direct action, indirect action. If I have high LAT radiation, I can do direct action. I can take out the DNA, cell dies, can't reproduce. Indirect action, I'm going to mess with the oxygen and hydrogen of water, and that will do a indirect action, a two-stage process. Also, with everything we do in x-rays, it's either going to be deterministic or stochastic. Deterministic means we know it's going to happen. We know it's going to happen. If I drop my keys right now, it's going to hit the ground. We know it's going to happen. Yes, ma'am.
So, isn't there something somatic too? Is that?
Stochastic? Yeah. Somatic. So yeah, somatic cells are germ cells. So soma is the body. So everything in my body is a somatic cell. Only my reproductive organs are germ cells. Okay. So everything we worry about is not everything, but most things is somatic. Okay, does that make sense? They're just two different things.
Okay.
Either it's a reproductive cell or it's part of my body cell. Okay. Deterministic, we know what's going to happen, but we do have a threshold. I'm not going to get red skin until I hit a threshold. If I don't hit that threshold, was there damage? Yes, but no one knows. It's a secret. Okay. So early tissue actions, late tissue actions. Stochastic, we don't know what's going to happen. According to our books, they're thinking that if we keep damaging our bodies over and over again with radiation, eventually it's going to cause a cancer, a mutation, which would be almost anything we do in our lives, right? That's going a little far on everything. Depends on what damage it was. Like we could probably survive quite a bit of radiation if we just don't die. Right? Because our bodies will fix it, maybe, but in fixing it, if we don't, when we start damaging things and we get it fixed and get fixed, eventually something's going to fix it wrong, and then we develop a cancer. Okay, does that hopefully makes sense? I don't think it was on my list. It may be here. Yeah.
Just saying, like, you could still give a lot of radiation dose, but still without.
Yeah. So your lethal dose, like you're saying, is that 50-30 or the 15-20, which says lethal dose is this for this much dose to these people, this many people, percentage of the population will die in this time zone. So usually it's like, 50, 100, 50% of everyone in here died from this dose in 100 days. And that's how they kind of know what happens. They kind of clump us all together. Here's your somatic effects. So the body, everything but our germ cells, okay, our genetic cells. So We are always worried about genetic cells being mutated by radiation because we don't want our kids to be mutants. But there is no evidence, so we know it can happen, but we have to have a lot of radiation. X-rays just aren't that much radiation compared to what you can do to someone. Hopefully the Chernobyl dog experiment will figure itself out. So somatic effects, what's that? Well, damage, kill a cell. What if I kill a cell or I damage the bond of H2O, start killing cells, atrophy of my organs, things don't go too good. Or somatic effect is I keep getting damage to my skin and develop melanoma because there's that one mutation, right? So either way, somatic effects, early or late, it's deterministic. We kind of know what's going to happen usually, okay? Know where we stop here. Early tissue reactions have to have a threshold. Nothing happens till we cross the threshold. I hate that thing in the way. And this does, obviously, the biological damage has to do with the dose. So at 0.25 gray, we might get some deterministic. It's a lot of damage, but maybe it doesn't show up. At 1 gray, 2 gray, we do know we're going to start getting sick. 4 gray, we get really sick, and at 6 gray, we die. There's your threshold. They're going to give you curves like this. So this is a nice curve because this is deterministic, saying that yes, nothing happened until I got past the threshold, even though there was damage, but no one knows it. And then I can only go so far as I increase the dose before I die, and then it's all over. Which is totally different than the linear non-threshold dose curve we do for radiation protection, which is kind of fake, but it's like every photon's bad for us, so protect ourselves. Don't know if they're going to get here, but about 6th grade, we're into acute radiation syndromes. Even before that, actually, I think it's a 0.5. So we'll go over those real quick, and then we'll okay, ARS. We're going to start with hematopoietic. I think we're at 0.5 gray, 1 gray. We start getting hematopoietic. And what is this? This is exactly what Bergoni and Trimanova was telling us. Our most sensitive cells are getting wiped out, our bone marrow. Okay, so platelets, we're going to bleed out. Lymphocytes, we're not going to have an immune system anymore. Red blood cells, we can't carry oxygen anymore. So that's the first one. Yeah, if you did a blood count, you'd see that you've gotten radiation damage and you're into the syndrome. This has to happen before this. This has to happen before this. So if you get this, yes, you have ARS, acute radiation syndrome. Once you get the gastrointestinal, that's your crypt cells, kind of just melting from the inside out. And then cerebrovascular, obviously, cerebrovascular, you start popping all your vessels up there because they're too weak to do anything. So, but this is like 10, this is 10 gray. You're not going to be alive by then. So I don't know who gets these. Maybe if you watch Chernobyl, you'll see that. Hematopoietic, 1 to 10, but it's 1, just say 1, and then you start having it. Gastrointestinal, 6 gray. Now, that's humans. We know that there's animals that can handle a lot more than that. Dogs can handle a lot more radiation than we can. Tardigrades, the little water bears, they can handle a bunch more than we do. So, one last thing, I think this is it. Yeah. When you do ARS, your body takes the damage, you get really, really sick. That's called prodromal. Then you have a little latent stage where you're all okay, everything's fine, that hurt, but I'm going to be fine. And then it comes back with a vengeance, manifest illness, and then recovery or death. I don't say recovery, I just say death. So.
Oh,
There's no
30 minutes.
Thank you.
Yeah. Yeah, so just remember prodromal, if you just remember that's the initial stage. You had more than a gray, you are going to be sick. Then latent stage, you're fine, everyone goes home, no funeral yet, you're going to be great, and then a week later, you're really, really sick, and then recovery or death, usually the latter. You don't need to know all that. I don't think they're going to do exact. Here's lethal dose, like Taylor was saying. just two numbers. First one is what percentage of the population is going to die from this dose, and then what's the time period? If you look at 50-30, that's kind of a ridiculous one because 30 days, it's a lot of dose. Have 50% die from that, but just do that. I mean, 3 to 4 gray, we're all going to be, yeah. So every time you see an LD, it's just what percentage are going to die from that dose in that time period. That's kind of how it works. It's not a linear curve. Remember, if we're doing radiation protection, it's a linear curve. It's fake, right? It's not real. It's like really conservative. This is real. I got 1 gray. I start getting sick at 2 gray. I'm getting really sick. 3, 4 gray. I'm getting really, really sick. And then by 6, I'm dead. How many times have we said that today? Lots. I think that's it. Do know if we do not get, even if we got a bunch of radiation, we are humans, have lived around radiation a long time. So there is always recovery, at least to a certain extent. Radiation oncologists rely on this. I'm going to kill this, but the surrounding tissue hopefully will get spared. It'll come back. I just hope it doesn't mutate. So they're called repair enzymes. They come in and repair things. They repair things from what you ate at taco time. They repair things from what you smoked or what you did with your life that wasn't probably good for you. So they are working all the time. Radiation isn't the only thing. We have 4,000 alpha particles pop out of our bodies every day. It's not enough to kill us, right? You live in your mom's basement, you have millions of them, so you're going to die of lung cancer from radon. So, do you want to? Did you put?
I'm gonna cover this.
Okay, sweet.
You probably need to drink fast.
Sorry, I have another class to teach. I'm going to pause record.
All right, so we are back on. This is just a continuation of, Shane's safety. So I'm going over the second part of the radiation safety segment. Yes. Do not want the computer to restart right now. Okay, so safety, you see that it's broken into 2 segments. So you just went over the radiobiology and physics portion with Shane, and then I'm going over the protection portion. So this is 29 questions of those 50 questions that you'll see in the safety section. Okay, so something that I want you to look at here is that there's 2 main categories when it comes to safety. Okay, first category is our patient protection. Okay, so how do we minimize our patient exposure? And then the second is personnel protection. How are we protecting ourselves? Okay, so some of the goals, of course, with radiation protection is we want to protect people, anybody who might be interacting with radiation from short-term and long-term effects. Avoid unnecessary radiation. That's why we don't just do x-rays just for fun. We don't do it on each other in lab. We know that there are potential risks. So we want to look at those risks versus the benefits. And it is part of the ARRT code of ethics. So when you pass your boards and become an ARRT certified rad tech, they're going to send you a list of the ARRT code of ethics. And those are things that you need to abide by. And part of that is radiation protection. Okay, we are responsible for ensuring protection of our patients, of ourselves, and anybody else that might be in the room or being close to the radiation that's being exposed. Okay, quick reminder that we have different sources of radiation. We have the natural and background radiation that we're exposed to just by living our everyday lives. And that can vary based off of our geographical location of where we live, right? And then we also have human-made radiation, which is a little bit more of the focus of what we deal with in medical imaging. Okay, so man-made radiation can also include nuclear power plants, working with nuclear fuel. That's where we see a lot of those issues with like Chernobyl and like TMI 2 events. And then we also have like the atomic bombs, Fukushima, different negative things that we've seen in history. And it's actually pretty interesting because we have more data on high amounts of radiation, that acute radiation syndrome that Shane was talking about. We have way more data on that from those historical events than we do on the long-term effects of low radiation over time. Because as Shane mentioned, those are things that we can't necessarily always predict. And we can't always say, oh, it's because of that one chest x-ray you had. right? It could be because you lived somewhere or you were exposed to asbestos, or maybe you were, there was other things that you may have been exposed to in your life, and it's hard to bring it back to, say that it was solely because of a radiation exposure. Okay, largest sources of the man-made radiation that we're exposed to is diagnostic medical x-rays, particularly CTs. CTs have a lot of dose. And then fluoroscopy and interventional are also up there with a lot of the dose that technologists are being exposed to. And then of course, dental x-rays. So you reviewed this with Shane. These are the different types of radiation. So I'm gonna, for the sake of time, we'll skip over that. But I'll provide my PowerPoint so you guys can review it if needed. But that just kind of goes over the different types of radiation. So first things first, how do we minimize our patient exposure? There's many things, but this is a huge responsibility that falls on us as the technologist. Okay, so the first thing you see listed there is our exposure factors. Okay, it is our responsibility to not completely rely on the machine and be a button pusher. Okay, it's so important that we know how to adjust our KVP and our mass appropriately so that it is specific to our patient and it's appropriate for the exam and everything that entails. Also, our beam restriction, make sure that we're collimating. Okay, that reduces scatter, so that protects the patient and anybody else that might be in the room when we're exposing somebody. And we're going to go through all these different things. We're going to talk about filtration and different patient considerations, how we document our dose, etc. Okay. So ideal for a good exposure factor is you want a high KVP and a low MAS. Remember that the mass is directly related to the dose, right? Okay, it's a direct relationship. So if you double your mass, you're going to double your dose. If you half your mass, it's going to half your dose. Okay, it's a direct relationship. We also have AEC, which is used in most modern machines. And if it's working properly, it's a great tool, but it's still important that we're using a high KVP for that part. And then basically what the automatic exposure control does, and I've got some information here, is it's going to determine the amount of time. Remember that mass is your MA multiplied by your time. Okay, so the time is measured in seconds. And so usually it's going to be at least 1 millisecond. But that's something that you might want to adjust, like for an infant, for example. Really fast exposure times help us to reduce motion as well. Okay. And so you're usually going to see a higher MA station and a lower time station if you were to break it out separately. So when you're working with automatic exposure control, you'll be able to select your KVP and your MA station, but it will determine the amount of time that the exposure occurs. Okay. So when you're looking at the cassette, Bucky, usually it will show you an outline of where these detectors are built into the system, and that's what's used for the AEC. Okay, so it says, hey, for a chest x-ray, we're expecting the Bucky, the cassette, to receive a certain amount of dose, and once it reaches that threshold or that amount of dose, then it will automatically terminate the exposure. So that's how it determines the time for the exposure. Okay, it's also why it's important that your body part of interest is covering the correct detectors. Okay, so if you, for example, let's say you were doing a hand x-ray and you place the hand right in the middle, you want the middle detector selected so that it knows that it's trying to read the amount of dose or the exposure that's hitting it there. If your hand is right here and this detector or even both of those detectors are selected and this middle one is not, then the exposure is going to hit those detectors without anything stopping it. The hand or the body part is not stopping it. And what's going to happen? It's going to be underexposed because it's going to say, oh, we got the dose we need, and it's going to shut off early, right? So it's very important that your positioning is set up correctly. The AEC system also has a default in there so that it what's called a backup timer. So if for some reason it's not processing it correctly, theoretically, it could just keep going and going and going and exposing the patient to extreme amounts of radiation, which we don't want. So the backup timer is in place that says, hey, once we reach 150% of that exposure or up to 600 mass, that's a huge amount of mass. But once it reaches that threshold, if it doesn't detect it by the detectors, then it's going to shut off the exposure. So that's kind of that backup safety system that's built in. Okay, when there are adjustments, usually it's increments of +1, +2, or -1, -2, and up to 3. And these are 25% increments. So for example, if you did a +1, it's going to do a 25% increase in how much exposure it expects to receive to the AEC before it shuts off. Okay, an example you can see here. Okay, so this one was a normal, or at least for that system was normal. And then this one was a +2. So it basically increased the amount of exposure by 50%. Okay, and what you can see is that you can actually see the detail of the bone a lot better when you had bigger exposure, right? So basically what we're doing here when we make these adjustments for the automatic exposure control is ideally you want the system to be optimized so that it's giving you an ideal amount of dose so that you can get diagnostic images. If you're regularly having to adjust it like +1 or +2 or +3 or minus, then maybe it's always overexposing and so you have to click the minus, that means it probably needs to be recalibrated. And the physicist has to come in and just readjust that. Okay. All right. So technical factors, again, we want to have higher KVP, lower MAS. When we have higher KVP, basically it's giving us more kinetic energy. Remember that the KVP is the kilovolt peak. It controls the energy or the quality of the X-ray beam. And so it has that kinetic energy going forward. And if you have higher energy, more of that scatter is going to be projected forward rather than sideways. Okay, so that energy is probably still going to be somewhat useful and it's going to hit the detector rather than staying in the patient or interacting with anybody else that might be in the room. Okay, so it's good to have that forward scatter when we have that high energy with the KVP. Okay. Remember, we have different categories of radiation. So primary radiation is the amount of radiation that is exiting the X-ray tube once you've produced an exposure. Once it's interacted with the patient, you're going to have scatter radiation that goes off and comes off of the patient. The patient is the #1 cause of scatter. And then the X-rays that exit the patient towards the image receptor is what we call our remnant or our exit radiation. We also have leakage radiation, which can occur coming from the X-ray tube when we've created the exposure. And we do have filtration and housing that's built in to help shield for that so that we don't have all that leakage radiation that's floating around the room. Okay, so we have that tube housing, which helps to reduce the amount of leakage radiation that might leave the X-ray tube when we get that production of X-rays. And the requirement for the protective tube housing is that it should not exceed 1 milligray in air. So that's that amount of air, right? At 1 meter from the source. Okay, so this is something that the physicist is usually measuring when they come in for their routine checks, but it's measuring how much leakage radiation is leaving, and this is a federal requirement. So at 1 meter from the X-ray source, it should not exceed 1 milligray in air per hour. Rex, are you next?
Yeah. Just
Okay.
wherever you're done.
Okay. All right. Okay, filtration. We have different types of filtration. So there's inherent and added filtration. This is basically helping with the absorbed dose of the patient, and it's filtering out the low energy X-rays. Okay, remember that when we produce an X-ray beam, it's a heterogeneous beam, right? So it has some energy, high energy, and some low energy X-rays. The low energy X-rays are more likely to just cause dose and be absorbed in the patient than to be useful. And so filtration helps to absorb the low energy X-rays. Okay. So the requirement for filtration, this is one you'll want to make sure you memorize and write down, is it has to be a minimum of 2.5 millimeters of aluminum equivalent, that filtration that's built into the X-ray tube system. Okay, so you can see here we've got the aluminum filter that's right here. And then we have the collimator. We have some filtration that's built into the shutters and the collimation beams. And then there's also tube housing that has that filtration. And we measure this in aluminum equivalent. So when you're looking at radiation safety, filtration is aluminum equivalent. When you talk about shields, it's lead equivalent. Okay, so you'll see Al, that's aluminum, and then what's the notation for lead? PB. Yep, so you want to make sure you get those separate. When you're talking about aluminum, talking about filtration. PB lead is our lead measurements for the shields. Okay, half value layer. This is the thickness of the filtration system that will decrease the X-ray beam by 50%. Okay. And there are different measurements for that. So this is measured once a year by the physicist. We measure this one also in aluminum because we're looking at filtration. And we have it based off of kVp. Okay, so I doubt you'll need to have this measure. You just need to understand the concept of what half value layer is. But you'll see here, based off of the kVp, you'll see that there's a minimum amount of, the millimeters of aluminum that's required to reduce the beam by 50%. Okay, we've got different types of filters. These filters can be used to assist us with the beam. So common area is the foot because near the ankle, it's a more dense area. And then as you go towards the toes, it tapers off. And to help get a more homogeneous beam and more uniform exposure, we can use filters so that we're basically near the toes where you might be overexposed. We're using that filter to absorb some of those X-ray beams so it's not overexposing the area of the toes. But it's usually a wedge filter, so it's absorbing more of the X-ray beam towards the toes and less towards the ankle. And therefore you have enough X-rays hitting the ankle area, not too many hitting the toes, and you can see that it's more uniform. Versus here, you can see that it's not uniform, it's starting to taper off and be a little overexposed towards the toes, and here it's more uniform. Okay. Okay, collimator is the current predominant X-ray beam limitation device and one of the most important things you can do in terms of protecting your patient. Okay, make sure you're collimating to the body part. Now, don't collimate so much that you're clipping anatomy and you have to repeat it because now you've doubled your dose to the patient, but make sure you're collimating because that not only improves the quality of your image, but reduces the scatter. Okay, so this is a couple of different devices. It's pretty uncommon that you'll see these, but sometimes you might see different collimator configurations, beam limitation devices. But basically what they do is they are going to collimate the beam before it hits the patient. So here we've got this image shows you the difference here. Here we go. So there are some devices where you can have like a cone filter or a straight cylinder cone that basically attaches to the X-ray beam, but it's pretty uncommon that you're seeing these anymore. Has anyone seen this being used? Okay, so this is, you can use it in theory and it used to be used more often, but not as often now. Okay. All right. Our dose area product is usually measured in milligray per centimeter squared. And this is basically the total sum of the air current of the whole exposed area that's being thrust towards the patient. So it's not necessarily how much was absorbed or what type of dose. It's basically just how much was exposed and thrown towards the patient. And that's what we're measuring in fluoroscopy is those DAP, right? And so we'll usually write down the DAP and the fluoro time when we're sending it in for a patient chart. Depending on the protocol at your facility, they may require you to record that, or it might automatically be sending over. Okay, B, this is the second portion. This is the personnel protection. How do we protect ourselves? Okay, so golden rules, time, distance, shielding. Okay, we'll cover that in just a second. Some of the main areas where we see the most dose to ourselves as technologists is going to be things like fluoroscopy, mobile x-rays when we're going towards our patients, C-arm, so like in OR or C-arm procedures, and general fluoroscopy. Okay, so time, distance, shielding. Decrease your time that you have to be in the room when an exposure is being made. If you're not there as much, then you're not getting as much radiation. Distance, if you do have to be in the room, make sure you increase your distance. Remember that we have the inverse square law, so we know that the farther away you get, the less the dose, right? And so ideally you want to be at a 90-degree angle from the x-ray tube and at least 6 feet away, and theoretically you shouldn't be getting any dose. Okay. So not only getting farther away, but strategically placing yourself will help you to reduce your dose. And then of course, shield yourself. If you have to be in the room, wear a lead shield. And it is our responsibility to make sure that everybody else in the room has the option to remove themselves from the room or to be provided a lead shield before an exposure is being made. Okay, you can't just zap everybody. Okay, you need to make sure that everybody knows that exposure is about to be made and that they have the option to receive protection before you go ahead and initiate the exposure. Okay, ALARA, as low as reasonably achievable. Okay, that's something you want to make sure that you are reducing the dose without compromising the quality. Okay. And we're skipping through pretty fast here. So these are some of the NCRP recommendations that you see. They are noted in the ARRT content specification. So I just want you to have them so you know what each of them kind of covers. So report 102 talks about that filtration that we just talked about. So a minimum of 2.5 millimeters of aluminum equivalent for the filtration system, and then the minimum lead equivalent for different protective devices. So that's what the NCRP report 102 covers. Yes.
Do we need to know the report number?
Yes.
What's underneath it?
Yes, it is these NCRP report numbers are listed in the content specs. So if it's listed in there, I would just make sure you know what they are. Yeah. And then 116 is just basically all of your doses, like for personnel doses and pregnancy dose and the general public versus your radiation worker exposures. That's what that covers. So the different monitoring.
A question.
Yeah.
Are they gonna try to trick us into like units? Cause I know in the NCRP, it's, I think it's just sieverts. But a lot of times on rad tech boot camp, it'll be like millisieverts. So my brain is gonna be millisievert.
Yeah.
It's gonna get me.
Yes.
People like.
You want to make sure you memorize it and know how to convert it. Okay, so you know how to move the decimals, right? If you're talking about sieverts versus millisieverts, just move your decimals so that you know what you're talking about. Typically, like you were talking about with Shane, some of those ARS syndromes, we're talking about sieverts or grays because it's large amounts. When you see our doses, we're talking millisieverts because we're not getting even close to that 1 gray or 1 sievert, you know, and so it's very small amounts.
Okay, thank you.
But there is a chance that they might try and trick you, so just pay attention to that. Yeah.
Thank you.
Yeah, no problem.
Yeah.
Yeah. Okay, so your employer is required by law to provide you with a dosimeter if you are expected to receive at least 10% of your yearly dose. Okay. Now, my thought on this, because I've actually had students that have worked at clinics where they don't provide them with dosimeters at all. And I don't know that you can actually tell, how can you know that you're not actually getting 10% of your final dose? So, but that's a federal requirement. They have to give you a dosimeter if you're expected to potentially receive at least 10% of the yearly dose. And so you'll also have the control booth dosimeter that's measuring just what's potentially getting into like the control area. Okay, so let's quickly review these dose limits. General public is 1 millisievert per year. For frequent exposure, and then infrequent exposure is 5 millisieverts. So the difference between these two is that, like, hey, maybe you have somebody that has a condition and you know they have to come in every year, all the time, or multiple times a year. And so that's why their dose is smaller, because they're doing it over the long term. Okay, so they're getting small doses over the long term. Whereas maybe somebody has an accident 1 year, they need to have a lot of exams and CT scans, but it's not expected to be a long-term thing. Then you can have the 50 millisieverts within a year. Radiation workers is 50 millisieverts for the year. That's our annual effective dose. And then our cumulative dose is our lifetime dose. So that follows you throughout your career. All right. And so that's 10 millisieverts multiplied by your age in years.
It's 10 multiplied by our age.
Yep. By your age in years. Yeah. So if you're 20, you do 10 times 20, that's your cumulative dose. If you're 30, 10, 30, you know, so on and so forth. And so that increases as you get older, but it follows you throughout your time. As a pregnant worker, the dose to the fetus is 0.5 millisieverts per month throughout the pregnancy and no more than 5 millisieverts for the entire pregnancy. And for pregnant workers, they have the option to voluntarily declare their pregnancy. And if they do, then the employer is required to provide them with a dosimeter for the fetal dose. Okay. And then I've got information here on the different leads. Maternity lead should be at least 0.5 millimeters. And I have the same chart that Shane had here that kind of goes over all the doses for the different body parts. So you'll see that there's some additional doses for like the hands and the lens of the eye, etc. Okay, the ones I highlighted are the ones that you're probably more likely to see on the exam, but you'll still want to make sure you're reviewing these. So the lens of the eye, hands. Yeah, well, those ones you'll want to make sure you know as well. But like they're more likely to ask you like the pregnancy dose or like your lifetime dose or the yearly dose. If you make one, love to hear it. Okay, I don't want to keep Rex, I don't want us to stay behind. So I will provide my PowerPoint. I'll get it to Tanya and have her send it to you on the Canvas course.
You address the thickness of the letter. It's like.
Yeah.
Sort of just this whole flip.
Yes, so it is a little bit confusing because the minimum is technically 0.25 according to federal regulations. But for the thyroid, it needs to be 0.5. For maternity, it needs to be 0.5. And fluoroscopy, it needs to be 0.5. So most of the time, you're going to have a minimum of 0.5 millimeters of lead. Okay. And if you were to answer the question on the test, it's probably going to be 0.5. It seems like AS or the ART kind of sticks to that 0.5.
Just to compare that much, why that-
Yeah. Yeah. Yes, unless it's you're in fluoroscopy. That's where it gets tricky. And Rex, I don't know if you want to give me some of your, if you have any insight on this too. If you want, you can join us. We're just talking about the lead shields because it is confusing because the federal regulation is 0.25 millimeters.
Yes.
But for fluoroscopy and thyroid, it has to be 0.5, and maternity, it needs to be 0.5.
Yeah.
So that's kind of the difference there. I don't know if you have any way to help remember that.
I would go with 0.5. Always go with the higher.
We should always answer.
Yeah.
Yeah.
That's what I typically say.
Straight there, but they're changed.
Yeah, 0.5 is gonna be your safer option. My best, I guess, estimate would be that the people that write the exam are not gonna have 0.25 be one of the distractors. So you're either gonna have 0.5, 0.4, 0.1, 0.05. So you're gonna know which one's gonna be that one. So 0.5 is what I would put there.
Yeah, there is like, so, and I have this in here. So if the lead,
Well, it depends on the KDP as well, but for
Yeah.
typically what we do, it's gonna be 0.5.
yeah, so it says for at least 100 kVp, at least a minimum of 0.25.
Yeah.
But where we're using, especially with the newer units, we're using like 140 or higher, we're using pretty high kVps. 0.5 is going to be used more often, but again, that's required for thyroid, it's required for maternity.
Yeah.
So in most cases, you're gonna just get 0.5s from a standpoint of like a manager. They're probably going to purchase and invest in 0.5s across the board because then they don't have to be like, oh, well, this one can't go in the fluoroscopy room, this one can, and
Yeah,
it makes it a little more
so
confusing.
they always just err on the high side.
Mhm.
Have that, and we can use it for whatever.
Yeah.
Is there? was there a
Gloves-
question in rad
Gloves
technique?
are 0.25,
Yeah,
so that's the one that you can answer 0.25.
Is there questions on the rad technique cap? That had that same type of question?
There's the one that put protective eyeglasses on that. 0.35.
Yeah.
Yeah.
0.35.
0.35 for lead glasses.
And always remember, anytime you're protecting with ferrules, always gonna be lead. Filters are always gonna be aluminum. So if they're talking about a filter, it's always gonna be aluminum. If they're talking about protective apparel, it's always gonna be metal.
Mhm.
I think you already mentioned 0.2.
Athletic, well, right?
What?
Yeah, if it's talking about shields, it's lead.
Any
If it's talking about filtration, it'll be aluminum. Yep. Okay, so I have those listed in there.
Yeah, filtration, yeah, so that's a big question.
Did you move this out of the way?
No, I just left it at the bottom, but you could probably move it if it's in your way. I think for them here, it's kind of nice to be down at the bottom. Just so they can't really be as far down on the screen.
Oh, okay. Yeah. Okay.
Okay. Let's go ahead and get started. Gotta do my dad jokes. So the bigger the classroom, taking notes, make sure I say it right. Okay, why do cows wear bells? No. Because their horns don't work. Their horns. Because they don't. What do you call a man standing in a hole with a shovel?
This.
Done. Okay, I'll do one more. I've got other ones too. Five ants rented an apartment with another 5 ants. Now they're tenants. I'll do one more. When does a joke become a dad joke? When it becomes a parent. See? There you go. Yeah, outstanding. It's good. All right, I'm not gonna pull this up right here. I think Tanya may have showed this to you in your 2913 class, but this is actually a good link, and I'll give you this PowerPoint so you'll all have it. This is a good link to go to ART, and if you go to earn your ART credentials, and then you look for things called what to expect on examination day, it has a ton of good stuff in there about how to prepare for the exam, what kind of exam questions there are. Casey, I talked to him a little bit, and I guess during his time slot, you talked about multiple choice or these multiple 1, 2, and 1, 2, and 3. Yeah, 1 only, 2 only. They've actually the last couple of years they've changed that and they call it a multi-answer question. So what that means is you're going to get a question, and it's going to say there's more than one right answer. So you may have A, B, C, D, E, F, G, all these possible answers. You're going to have to select whichever one is correct.
Does it tell you how many, like on contact, select free or?
It may and it may not, so. Yeah, if it doesn't, then you're like, it could be 1, it could be 2, it could be 4. I don't think there's gonna be that many of those, but the key thing is that and everybody does test different. This is just this is how I do it. Okay. I don't look at the distractors. I read the question, and then I just sit and think about that question. What do I know about that question? Try to think about everything you know about that question. And then I look at the distractors and I make them true, false questions. So, okay, here's the question. Here's the answers. True or false? Oh, that's false. True or false? Maybe. So I put that on the side. B is possibility. C, true or false? That one's false. D, true or false? Possibility. So now I'm looking between B and D. If you're not 100% sure, and again, this is the way I do it, I flag it. And then I go back, because what I found is, for me, my brain has to get warmed up. So at the beginning, When I first start off, my brain's not fully engaged in the test. So then as I start reading these questions, and now I'm like, okay, I've read some questions that are similar to what that question was I flagged. I'll go back and answer that. Kind of have my brain and stuff. Yeah.
So is the board exam similar to the LPT exam where it's sections and you can't go back? Once you
No.
pass the section, no.
No.
It's the whole 220 questions, and once I get to the end, I can go back to the flagging questions.
Yeah, you can.
Well, sometimes they will kind of answer their questions.
That's exactly what I'm alluding to.
Sorry.
Yeah. They're supposed to go through and edit those when they do the item writers, the people that actually audit those questions, they're supposed to go back through and look for things like that that'll give future questions away and get rid of those. But there's still some subtle things that help you remember, okay, that one was true, or that one was this. Now I can go back to that. Yeah.
Record.
What's that?
Is it once you're ready to record?
I hit record.
Oh,
Okay, yeah, I hit record. So, okay, but thank you, because there are times I've forgotten. All right, so I'm gonna go over some things with computerized imaging, and we kind of got a late start, because we gotta kind of stack it up. So,
Run down to the office for a second.
okay, so,
I probably need to talk. Yeah, like.
Okay. okay, that's good. And I'm happy to answer any questions. I don't have to stick to a particular format. If you want to just go through questions and answers, we can do that. Or if you want to go, Tanya told me that you guys had some questions about the domain, the different domains. So the image domain, frequency domain, CR and DR, I'll talk about those, we'll review those. And then some of the quality assurance questions. So remember, there's two domains. There's the location domain. And when we talk about the location domain, we're talking about pixels.
Wait, so that one more time?
When we're talking about the location domain, we're talking about pixels. So pixels are the elemental unit of an image. So if we are, what's the elemental unit of water? There's H2O, right? Those are the elemental units, I should say, of water. The elemental unit of a picture is the pixel. And in the location domain, the resolution that determines whether you're going to be able to see something very small is determined by the size of the pixel and the number of pixels. So the number of pixels is our matrix. So we have columns and we have rows. The combination, if we have 12 columns and 12 rows, that's a 12 by 12 matrix. We times those together, we have 144 pixels, right? If we talk about, if you get a question about pixel pitch is actually, I'll move this over so people can, I don't know if they can see this on Zoom. So if we have pixels here, like this, we'll just keep it simple. If I measure the center of this, and I measure the center of that pixel, and I measure these two together, that's the pixel pitch. So if the pixel pitch gets larger, does that mean we have better spatial resolution? No, because if I was to do it this way, like this, now my pixels are smaller, my matrix, I have more pixels. Now I measure this. Which one's shorter? That one. So that means that as the pixel pitch goes down or gets shorter, means my resolution is going to get better. Now, when we're talking about resolution, we're talking about spatial resolution. So, okay. So when you hear location domain, it's all about pixels. All about pixels. When you hear frequency domain, that's going to be different. It's all about frequencies. So when you hear the frequency domain, that's when we're talking about high and low frequencies. So again, here's our location domain. This is literally, we have the X line here, the Y coordinates, we can actually say, okay, if I was looking at the image.
Can I pause for
Yeah.
a second? Would you be okay if we had to get some pizza while
Yeah.
it's hot?
Yeah.
We have pizza here. Why don't you come down and grab some pizza? And then head right back up so that Rex can continue. We'll pause the video. We'll pause the video. Yeah.
Yeah. Yeah, just don't make a mess.
And then there's the technical, right?
Yeah, it's more in the. You guys are all gonna be eating.
Oh, so good.
Well, be quiet. Be quiet.
Yeah, there's.
Right.
Doritos, you did eat your bag of Doritos. Yeah, potato chip.
I need to take, everything's like final, but other than that, I believe so.
I get behind my notes. I'm like, try to listen and then I'll go back and try. There's. I am the one that did that. Okay. I honestly don't even hear you. Just come on back. Well. You know, John. John just.
Yeah, you're welcome, you guys.
Okay. All right. You don't wanna, yeah. Pizza makes me sick. So you don't wanna be pizza. You're gonna get a little more sugar in your brain. Okay, let's go ahead and get started while they're finishing up. So. Location domain, we can actually pinpoint the location of where the pixel is based on the location domain. So if I had a picture here of a head, where, like if this is the forehead or the eye, that's where that would be. So it would be equivalent to wherever that's on the image. Somebody talked about bit depth. So bit depth, remember bit depth is going to be the number of shades of gray that you have. So it's whatever power, 2 to whatever power, 2 to the second power 2 bit depth is going to be 4 shades of gray. 2 to the 8th is going to be 256 shades of gray. So 2 times 2 times 2 times 2 times 2. Okay. All right. See, these are the characteristics of a digital image. You have the pixel, you have the pixel size, the pixel bit depth, that's the shades of gray. You have the matrix, that's the number of pixels you're going to have. And then you have the field of view. So like over here, if I was going to change my field of view on this image, and I still had a fixed amount of pixels. So in this case, let's say this is 12 by 12. and I change my field of view to a larger field of view, what's gonna happen to my pixels? They'll get bigger, so the spatial resolution.
Same amount of pixels.
So, yeah, so if I keep the same amount and my field of view goes bigger, then my pixel gets bigger, which means my spatial resolution goes down, okay? If I was to take the same amount of pixels, 12 by 12, so 144, my matrix is 12 by 12. If I put the field of view smaller, my pixel will be smaller, the field of view will be smaller, so therefore my spatial resolution is going to go up. Now, when you look at a DR detector, when you collimate down, it is not, I repeat, it is not going to change the pixel sizes. So when you buy a digital detector, a DR system, you're actually going to buy it with 1 million pixels, or 2 million pixels, or 3 million pixels. So if you collimate down to, let's say it's a 14 by 17 DR receptor, you're not going to use that 1 million pixels that it has. You're going to only use the area that you collimate down to. Does that make sense?
Yeah.
Okay. All right, so here, and the more pixels you use, like when you zoom up, you can see all this, we call it stepping. It's pixel stepping. So the higher the spatial resolution that you use, the less of this you're going to have when you zoom up the image. We don't want this because now we can't differentiate the borders. So we want to have a lot of pixels, many pixels as possible. This is the bit depth. So the shades of gray in between, that's going to determine the bit depth. Remember when I taught you this, I used the analogy of crayons. When I was a kid, you know, I got my little 8-pack of crayons, and I was on cloud 9, and then I got the 16-pack, and then the 32-pack, and the 64-pack, and I had a lot more colors to choose from. And that's what, the higher the bit depth, the more shades of gray you're gonna have. Okay, so anything that's related to bit depth is going to be shades of gray. Anything related to bit depth is going to be shades of gray. Yeah.
If your matrix is, oh gosh, if your matrix is bigger, do you have a higher bit depth?
It depends on the machine. So the modality or the machine that you buy for that modality is going to have a fixed bit depth. So like when I was a PaxAd man, we had a X-ray machine that was by Philips. It had a 16 bit depth, which I don't know, I can't remember how many shades of gray that is. Times 2 times 2 times 2, 16 times, and you'll get there. You're gonna even want to do that on your phone. It'll say how many shades of gray, but that's the limit. In that case, that's a high bit depth. So the higher the bit depth, the more shades of gray you have. But it's not dependent on your matrix size, it's dependent more on the machine. Okay, so when you're buying a machine, and that's what I've tried to do when I teach you, I'm trying to teach you like you're going to be working as a radiology manager or a read tech. When you buy a machine, this is what you want to look for. If you really are doing a lot of shades of gray, like in breast imaging, when you do mammography, you want lots of different shades of gray. You want to see all those different densities within the breast. So you're going to want to have a high bit depth. If you have a really low bit depth, like let's say 6, you're not going to be able to see all those shades of gray.
So back to the matrix and
Yeah.
things. So I understand it on the computer side of things and viewing it, but on the detector element or on the cassette IR, it's still, you still call pixels there? Right.
Yeah, well, you can call them diff, like on a DR, you call them diffs. So
Right.
a detector, yeah,
Okay.
yeah.
But sometimes they might be referred to.
And they can be referred to DELs on a monitor as well.
Oh, really?
Yeah, so on a monitor, when you look at, they will call it DELs, but on a detector. So when we talk about like a DR detector, they may call them DELs. The DEL and the pixel is going to be this.
So we just have to read the question really carefully to determine whether it's on the monitor side or the.
I don't think you're gonna have questions that make that much detail. I mean, you're going deep in the weeds on that. Okay. So it's just kind of, yeah, and that's one thing I will tell you, it doesn't matter whether you use RadTech, Boot Tech, RadTech, Boot Tech. I'm thinking of Correct Tech. I'm merging the two together. Rad Tech Boot Camp or Correct Tech, which is what we used to use, they always over test you so that you're actually more prepared than you need to be, which is a good thing. But I'd rather be over prepared than under prepared.
But sometimes it just.
You're absolutely right. I think sometimes it does. But they're trying to give you as much information to make sure you're prepared in all areas. So. Okay, so this is just shown here. Remember this equation, pixel size is going to equal your field of view divided by your matrix size. So if I had a 10 centimeter, well, let's say I had 10 centimeter field of view, divide that by a matrix size of 5. The pixel size are going to be what? 2, right? Okay. Here's our bit depth. So here we have 2 bit depths. We have 4 shades of gray, 4 bit depth. So 2 times 2 times 2 times 2, 16, 6 bit depth. 64 goes up to 10. So this is 1024 number of shades of gray. So again, this is something that you technically aren't going to be able to change the bit depth. That's again based on the machine. Now let's talk about spatial frequency. So what happens is when we look at an image in the location domain, that's really easy. We can see those different pixels. It's just like on our TV. When we look at our TV, those are all different pixels. If we have a 4K TV, it's close to on the linear side. Again, this you don't have to get into this. It's just Sheldon and me get kind of going on. It's almost 4,000 pixels. So that's why they call it a 4K TV. So the more pixels you have, the more things you're going to be able to see, the better the spatial resolution you're going to have. So now if we switch to the frequency domain, what we're doing is we're taking that location domain. It's going to go through the Fourier transformation. So think of the Fourier transformation as a mathematical box. It's like an algorithm. It's basically going into this box. And now it's going to say, I'm going to take all these densities and I'm going to convert them into wavelengths, short and long wavelengths, high and low wavelengths. Because we can manipulate those frequencies to help us with different things. And then after we're manipulating it, it goes through what's called the inverse Fourier transformation, and it goes back to the location domain. Okay. So this is where it gets a little tricky because we are not used to thinking of pictures as wavelengths. We're used to seeing pictures as shades of gray, or pixels that define the image. So this is where we have small structures or produce the high frequency. Those are responsible for detail of the image. Large structures produce the low frequencies, and they represent the contrast of the image. So what does that mean? Again, Fourier transformation or FT. You don't need to know this. This is what physicists, they learn all about. You have to have like a PhD in math in order to understand how all that works, which you don't need to know. So let's go to here. I showed you this before. This is a picture of this gentleman here, and we call this frequency domain, we call it K-space. All right, so this is a picture of this gentleman. These are the different wavelengths in here. If I only look at the center, which represents the low frequencies, then I'm going to see these shades of gray. I'm only going to see the contrast of the image, the different shades of gray. So that's why here we can see the black, he's got this black hair, he's got the white shirt, kind of intermediate gray hair jacket. We can see all those different shades of gray. But if you look at the lines that delineate those different structures, it's really fuzzy. It's not really sharp. Whereas my son, when he's little, he'd call it sharp. It's sharp, Dad, not sharp. Sharp. It's sharp. So if we're only looking at the center, those are, again, the low frequencies. If we look at the outer, we're looking at the high frequencies. So the high frequencies will show all the details of the images. So all the edges that we see here, we'll be able to see all the edges, but no shades of gray. So for edge definition, when you hit the button to see the tip of the pick line. And it sharpens that image. What you're doing really is you're seeing these outer edges of the frequency domain. So you're seeing just these sharp edges of the image. And that's why it's kind of cool. Like, how does that work? When you smooth out an image, so if you're doing like a cross table hip, and it's a little bit grainy on the proximal side of the hip, and it's okay on the distal side, you want to smooth it out, then what you're going to do is you're going to do a low pass filter, and that's where you're seeing the center frequencies. You're seeing those low frequencies, and then it smooths it out. So it doesn't look so grainy model. You see that model or noisy image. Okay. So that's one of the reasons why we want to use a frequency domain. It's because we can manipulate that, we can sharpen it, we can smooth it, we can do all these things that we can't do in the image or location domain. Okay. All right. This again, so high pass filter. We're going to sharpen things. Here's the original. It's going to sharpen those edges. Low pass filtering. Whoops. Does the opposite. So we're going to smooth it out. Doesn't look really sharp, but it's going to smooth out that image. So it doesn't look so grainy over here. Okay, any questions on that? Okay. I want to go through spatial frequencies. So when we talk about going back to, remember, the location domain, what determines spatial resolution? Pixels, right? So the higher the pixels, the higher the number of matrix, the more spatial resolution we have. When we talk about frequency domains, we talk about line pairs per millimeter. And the way I want you to remember this is I had a teacher in 5th grade. He used to huck chalk and erasers at us if we were talking. And I remember my buddy Rick Peterson, he got hit in the back of the head, this chalk. My teacher would have loved this. Christian, shut up. All right, so if we look at this, frequencies are just nothing more than a measurement, right? So measurement from this peak to this peak. If we are comparing frequencies, which one's going to be long and which one's going to be short? This one long, this one short. So this is long. What's this one? Short. Okay, so when we're doing this over here, we're actually going to compare these line pairs similar to these peaks and valleys. So when we have a sinusoidal wave, we have a positive lobe, then we have a negative lobe. So think of this positive lobe as this is this part. The negative lobe is this part. So over here on the left, would you say that's a long frequency?
Yeah.
Or a short frequency? It's a long frequency. You remember what I said about location domain? Long frequencies are responsible for contrast. Short frequencies are responsible for spatial resolution, right? The edges, the details. So if I take this and look at this and say, out of this, if I had to choose between this side and this side, if you can actually see in between these spaces, which one's going to have better spatial resolution? The one on the left or the one on the right? One on the right, because as it gets closer and closer together, these interspaces are becoming shorter and shorter. The wavelengths are getting shorter, higher frequencies, meaning better spatial resolution. So in the frequency domain, if you have a question about frequency domain and it says which is the better spatial resolution, and it says here 0.05 line pairs per millimeter or 5 line pairs per millimeter, which one are you gonna say? 5, right? Because the further we go to the right, the higher that number becomes, the better the spatial resolution is gonna be. So in the location domain, it's the number of pixels and the size of pixels. In the frequency domain, it's actually our line pairs per millimeter. So the higher the line pairs per millimeter, the better the spatial resolution. Okay. Modulation transfer function. Let me just go to this. So this vertical axis here, horizontal axis here, they're different. This one's going to represent contrast, so shades of gray. This one's going to represent spatial resolution, so our details. Each one of these lines represents a different type of detector. Okay, so we have a flat panel detector. This is with cesium iodide. This is a flat panel detector with amorphous selenium. This is a storage phosphor. That's going to be our CR, and then we have screen film. That's going to be just the old film that we never use anymore. So what you're looking for here is modulation transfer function really is looking at the relationship of the amount of contrast you have. So how good is the contrast of the image in relationship to the spatial resolution? So as this moves to the right, this one's staying pretty high. So this is 100%, this is 80%, 60%, 40%, 20%. If this stays up close to 100, that means we have good contrast, good delineation between black and whites.
So would it be considered like black and white?
You can see the black and whites better. As you move further to the right and it starts to dip, then that differentiation goes where it's more smooth. It's not really super black and white. But this is, see how these are dipping down? So these, we lose contrast as our spatial resolution increases, which goes back to these. So here we can see really good black and white, black and white, black and white, good contrast. But as we get further along, as our spatial resolution increases, we don't see that anymore. Contrast dips. So that's what this is showing, is just that correlation between our contrast, our black and whites, how well we see those, versus our spatial resolution. When we talk about contrast, they may say contrast resolution. So when you talk about contrast resolution, that's your black and whites. That's your shades of gray. That's your bit depth. When they're talking spatial resolution or spatial frequencies, that's your details of the image. Being able to delineate those lines and see those small, tiny features. Okay. Does that make sense? Any questions on that? Okay, I'm running out of time. I could talk for like 2 hours. You're like, yeah, go for it. Let me ask you this. Don't be shy, all right? Because what's the sound of the saying go? The only dumb question is the dumb question, or the question that you don't ask, right? So don't feel like you're asking a dumb question by raising your hand. What things are you struggling with? More on what? Okay. How many questions are you gonna have on the test about modulation transfer function?
How many dumb down?
One?
Yeah.
Maybe one.
Dumb down. Yeah, don't stress. Just dumb it down real quick.
Okay, if I was telling somebody in grade school, this is what I would say. You have black and whites, right? Shades of gray. And then you have details of the image, the lines of the image. So if I was coloring in a coloring crayon book, I would say the lines of that image are the details. That's the spatial resolution. That's the spatial frequency, the details of the image. The actual color that I'm using when I'm coloring a picture is the contrast. Okay, so as
that line moves to the right. All modulation transfer function really is. It's a comparison between the number of crayons you have and the lines of the details of the image. So I could draw a picture of a sun, literally a round circle and some lines coming out. Or I could put some lines on the surface of the sun and some little eruptions. I'm adding more details, I'm adding more lines to that. That's adding more to the image. If I add more colors to the image, that's the contrast. So what this is doing is basically saying, as I move over, this is the one I'm going to look at. I can use lots of crayons up until a certain point where I start to dip. As I add more lines, I actually lose some of the crayons. So as I add more details to the image, I can't use as many crayons. What's that? Yeah, so that's really all it is I'm just saying, as this moves over to the right, I get more details of the image, I can't use as many crayons. And then it drops it in.
So the higher the population.
Yeah.
Okay.
And yeah,
The higher that is, that's more black and white. Like
yeah, the more, well,
black and white.
the more, just going back to the color analogy, the more colors I can use.
Oh, the higher
The more colors I can use, the higher it is, okay? Okay? You wanted me to dumb it down, so,
Thank you very much.
does that make sense?
Yeah.
Okay.
MTF for zealots.
So the contrast would be the number of colors, yeah, so,
So I thought modulation transfer function was the ability to display on the image exactly what the real anatomy was. How does that fit into this? Or am I?
oh, it totally fits in, because if you don't have a high modulation transfer function, you can't delineate all the different colors of the image, the detail of the image. That's, as this dips down like this, you lose that ability to see all those details and colors of that image. So yeah, you're totally right. It is.
Higher than, yeah.
And it's not just an X-ray, it's in photography. So when you do photography, it's the same thing. The high, like if you buy a brand new camera, this is the modulation transfer function. That camera is this, it's a high number. That means it has the ability to see lots of colors, lots of lines, better detail. Okay. But you can't have your cake and eat it too. That's the whole thing. Ideally, what would we like? We'd like to have this line go all the way straight across, right? We'd like to be able to use as many colors as we want and have all the lines and details that we want, but in a perfect world, we can't. So we lose some of that as this moves to the right.
So the higher the modulation transfer function, the higher the space, the detail.
Yeah, as it moves to the right, this is your, remember, so spatial frequency, line pairs per millimeter. The higher that number, the better the spatial resolution is going to be.
Right, but you're not.
It's gonna be less black and white and more every.
But you're going to lose some of the colors because of that.
So we lose contrast when we gain spatial resolution.
Yes, exactly. You lose contrast, you gain spatial resolution. What they do, and this is just going a little deeper, when you buy a machine and they say this machine is so many line pairs per millimeter, what they're measuring is where this dips at 10%. So if this comes over, if we were to draw a line right here, this detector dips at 10% right here at 3. So its modulation transfer function is 3 line pairs per millimeter. That's where, that's what they call it. It's a 3 line pairs per millimeter machine. Because that's where it dips to 10%. Okay. All right. Any other questions? What about DR and C?
No, I bet we're gonna keep going.
Want to keep going?
No, about this, other stuff.
Other stuff. Okay.
How much do you think they're gonna, I don't want to focus on DR, but do you think it's more focused on DR than CR?
So they won't have, I don't think they'll have as much because that's phasing out.
Yeah.
It'll be more on DR. So the one thing I would tell you on DR to remember, let me just go to this. I'm gonna go to this right here. This is CR.
Let's talk about this. Yeah, I want to get rid of this. So the one thing, when I was a kid, I used to play those games where one of these things is not like the other, one of these things is not quite the same. You look at something and you go, what's the difference between all three of these? You'll notice that these are, you can't see it, but these two on the left are indirect detectors. This indirect. This one on the right is direct. So why are these two indirect? You remember?
Because they change it a lot before they change.
Exactly. So they change the photons, the X-ray photons are converted to light first, and then they're converted into an electrical charge. So you'll see these two, what do they have the same? They have a scintillator. What is a scintillator? A scintillator just scintillates light. So remember, I think I told you all this during Halloween, when you have those little plastic, like a ghost or a pumpkin that's green, and you shine your flashlight on it. You shine your flashlight on it and go in your closet, turn off the lights. It glows. That is, it's illuminating, right? It's a scintillator. It's scintillating. There's actually phosphor embedded in that plastic that is scintillating from that light. The photons of light hitting that create this green glow. And that's what the photons, the X-ray photons, when they hit the scintillator, they create light. That light is then, it goes through, on this one, a photodiode, just put it in your brain. A photodiode is, it's a, you're going over. Yeah. After the hand baby. Kim would never get mad, right, Kim? I can. No, it's so think of solar panels. When you see photodiode, it's a solar panel. You're taking light, you're converting it into electrical charge. That's what solar panels do. You take the light from the sun and convert it into electrical charges. Those electrical charges are stored in this thin film transistor. So this thin film transistor is just a storage bay for electrons, for electrical charges. So these two are going to use light, and the two scintillators, remember what the two scintillators are? Who we use? Who's going to use? Gadolinium oxysulfide. So, yes. Which one has better spatial resolution? Cesium iodide. Why? Has, like pencils, straws. I like to think of them, if you take a bunch of straws, put them together and you shine the light in, you have the light going through. Okay. Cesium iodide. Gadolinium oxysulfide is more facets, so when you shine light, it kind of goes everywhere. Okay. What's the difference about this one? So we'll finish up here. This will end on this. What's different about the direct detector system? Yeah, there's no scintillator. So it's going straight from an X-ray photon into an electrical charge. And we call that a photoconductor. And what's the photoconductor that we use? Amorphous selenium. What does amorphous mean? We use a lot of amorphous. Has weird shapes, yeah. It means irregular shape. Morph means to morph into something. Amorph means it has a weird shape. Okay, it's not a normal shape. So these are just little crystals that when X-ray photons hit it, it converts it into electrical charge, and it's stored again in the thin film transistor. So what's the goal of digital detectors? Remember, what's the overall goal? Because it's important you understand the why. If you understand the why, then this will all kind of make sense. I know you're all like, it'll never make sense. But what's the why behind why we have detectors? Well, yeah, of course, you want to take X-rays, but what is an X-ray photon? It's a packet of energy, and be a little more specific. What kind of
energy is it? Is
Well, it's light.
it's a waveform, right? So it's waveform like this. It's on the electromagnetic spectrum, so it's not visible light. But it's this right here. So we have a waveform. The X-ray photon comes in, goes through the patient, hits the detector, and then we want to convert that into electricity. Why do we want to convert it into electricity? Because we're going to send it to the computer. And what does the computer understand? Zeros and ones, which is really 0 is off and 1 is 5 volts. The combination of those zeros and ones, if we have 1 bit, that's a 0. If we have a byte, that's 8 combinations of 0, 1, 0, 1, 0, up to 8. So 8 bits equal a byte. And that combination of those zeros and ones means something to the computer. If you want to do something fun, put your name in and say, convert my name into binary language of computers. And it'll say 0, 1, 0, 1, 1, 0, 0, 1, 1, 1, 1, and that will be your name. That's what your computer, the computer knows your name by those zeros and ones. And all those are electrical charges. So when you're taking an X-ray and it hits that detector and it converts into electrical charge, it says, okay, this is how many photons hit this part of the detector. And if it's black, that means a lot of X-ray photons went through. If it's white, that means a lot of X-ray photons got absorbed by the body. That's why bones in the body are white. And that's why air on the X-ray film is black, because the photons go through it. Okay? All right, any other questions before it's time to go on? We got to get started in the games. Okay, so
Upstairs, 12 more people come get it, right?
any other burning questions? Things that you're gonna lose sleep over?
All of this.
Modulation, frequency function, down, right? Check. Okay. I just.
Question for you.
Yeah,
Really quick question.
yeah.
So when we're discussing like this matrix and bit depth and everything, we're referring to the matrix of the detector, correct? Not the monitor.
Yes, correct. Yeah, so it's the monitors is a totally different animal. Yeah, so let's say, for example, you have a 1 million pixel detector, but you only have, let's say, 250,000 pixels on your monitor. Your detector is better than your monitor. That's why when we go over to the ER, when we go into the radiologist reading room, they have those nice big monitors. Those are like 2 megapixel, 3 megapixel, megapixel meaning million. So 2 million pixels, 3 million pixels. They're doing mammography, 5 million pixels. That's, yeah, they don't have the visibility to see those in more resolution than what you're acquiring it. It doesn't really do any good to have a good detector. So, yeah.
Thank you.
Yep. Okay. So much to talk about and so little time. Sorry. I'm trying to see. I know. I'm sorry.
So you just reach in there. Okay. Let's record. Do I need to stand anywhere so that they can see me or hear me? Well, I'm not gonna be standing right here. I'm gonna walk. I'm hoping they can hear me.
Oh, yeah. Text me when they're done. And if you guys are done at that point, we'll let you go. If you need something from me, I would be happy to stay here, okay? So don't think that I'm leaving you. I'm here.
Okay, let's let Tanya know. Do we let Tanya go home or do we let Tanya come back? Do you guys want Tanya? Love you guys. Honestly, can your brain visit another hour? One more hour, I'd be like, my brain's done.
Okay, well then, here's the deal. If you will send me, like after you're here, if you will send me any topic that you want me to cover in a quick video on Monday, I will record that video and put it on your phone. Whatever topic you want, and it can be anything under the sun, as long as it's appropriate, ladies. Any topic, okay? Any topic. I feel like hardly because I do need to have a plan. We could really go there, but I don't think it's on your boards. But anyway, just so you all know, I'm actually going to be in Denver during graduation. It's not expected. I have to go to a board meeting, but I won't be there to shake your hand and give you hugs. So can I tell you, congratulations and how proud I am of all of you. You are amazing.
Me and Rob, and then you're done.
And you're done for tonight.
Unless you love Tanya so much, you just wanted to stay and teach physics all night.
I will stay. All right, well then, send me if you want something, send it to me. I'm more than happy to help you guys, okay? And congratulations. I can't wait to see all the passing scores. It makes my heart warm. Okay? And
do you want us to just email you if we pass?
please email me. I will give everybody an A that passes. You guys get like a response that tells you what your scores are. And I just need you to upload a screen or like a picture of that. And I will totally give you A's. It doesn't matter if it's, as long as it's before July 5th, I will totally change your grades. Even like, so please get at least a C, okay? Because that means that you got your associate's degree. But other than that, like if you really want an A and you pass this test, I will change your grade. I just want you guys to be successful.
What do you want us to send you a picture of?
They'll send you your scores, and then all you have to do is send me a score picture. But I know you have it in you. We can really trust you guys and love you.
You too.
And congratulations.
Thank you.
Now I get you.
It's so good to see your face. I miss you guys. Let's get a teach stuff here. Look at you guys. I've been, okay, I gotta tell you though, this made my day. I've been missing so much on morning, so walking around at night, it's very. So I have been to the facility.
Do you remember when?
Oh, you stole our phone.
Okay, yeah, as soon as I saw the picture, I did not.
Yeah, you texted me immediately.
I did. I'm like, well, the first time I called was Rob. I stuck out and I was out with the heart.
Wait, the one when he's standing. Yeah.
No, thank you. It really made my day. I don't know if I like it right there. It's kind of bothering me, so.
We can put it up higher.
That's okay. Maybe I'll put it in front of the cameras. But so good to see you guys. I want to talk to you and be like, how's your dating life, Christy? Or partly, are you engaged still? I need to know your life stories here. You're what?
I'm working on it.
Oh, I'm like, what?
No.
I should have brought my cards, right? They saw my card trick in Las Vegas. I'm pretty dang magic. Does anyone have a deck of cards? I'll show you if they have a deck of cards. I'm sure somebody carries one around in their purse.
Mom, let me tell you.
I wish there was. If there was, I would show you. Cards are back on campus, hit me up. Maybe I'll bring a deck of cards and keep them in my office. I have a really good card trick. I'm pretty magic. Okay, let's go into anatomy. What is it that you guys want to learn? Are you feeling like you need to learn skull? All right.
That's on side.
Skull spine?
Oh, we were talking. Ready then.
Skull, spine, and what did you say? Skulls, okay. Oh, I had to show.
Philosophy would be like, is this one AP or?
Rob's doing fluoroscopy. So here's some of the fun pictures I found today. Rob has a couple more too. I'm sure I'll find more as I go. I keep taking pictures. And these were the culprits right here. So, love you guys. All right, let me find my skull. I have tangential knees on here too. All right, skull. Skull is so fun. So let's go into review. There are 22 bones in your entire skull.
Sorry, is there a way you can share your screen with us?
They kind of sit everybody.
Did I not share my screen? Hang on. I thought I unshared it. Now I have to share it again. Sorry, guys. Can you see it now?
Yes, thank you.
Okay, thanks for letting me know. Dadgummit. Okay. 22 bones in your skull. Remember that 18 of them are your cranium bones, 14 of them are your facial bones. All right, let's review what those bones are really quick. So in your cranium, what are your cranium bones? Which ones are your cranium bones? Frontal bone. How many parietal bones do you have? Two. Laser doesn't work in here, does it? Okay, mine's not working at all. How many temporal bones do you have? So there's 1, 2, 3, 4, 5. What else do we have? Part of the occipital. There's 6. What are the other 2? Sphenoid and ethmoid. Good job, Dwayne. All right, sphenoid and ethmoid. I have your honors robes. Please come see me. How am I going to get them to you? I leave them somewhere upstairs? Come get them after I'm done with this. Okay. All right. Facial bones. We'll get to that in a minute. Let's talk about our radiographic landmarks. What is this called right up here? Labella. What's this? Avion. Pantheon. Hey, I don't think that these people can see. Sorry. I'm pointing right here. What is this called? Inner canthus, outer canthus. All right, so we use these like when we're talking about where the central ray is going to be entering at what level when we take skull images. This shows your inner canthus, it shows your outer canthus and the acanthon, and again, your chin is your mental point. Then we have most of these lines that we use go from our EAM and usually go to probably the orbit and then just infraorbital. So remember, the OML is your orbital meatal line. So from the edge of your eye to your EAM, that's your OML. Infraorbital is just below the orbit to your EAM. How many degrees difference are there between those two lines? 7. Why is that important? Because of what? Yeah, it depends on how you're lining your patient up, right? So if you're lining the OML up, you might angle 30 degrees on the towns. But if you're using the IOML, you would use how many degrees? 37. So you guys are got this. You're going to ace this part. So just remember for technique, the general technique is about 85 kVp for skull imaging. If you want to do an AP skull or a PA skull, it's about 10 mass. If you do a lateral, what do you do to that mass? Cut it in half, because instead of going from central ray from here to here, we're just going here to here, it's half the distance. Cut your mass in half. If we're doing towns, it says double the mass. Do you remember why we double the mass for our towns? Huge angle, right? We're doing like a 30-degree caudal angle, so we're going to double the mass. Waters, it says it's a little more than the towns technique. What do we do when we encounter sinuses? How do I get rid of this?
Are you gonna make these slides available too?
I can definitely do that. How do I get rid of that? Just drag it, maybe. Okay, so if we're doing sinuses or facial bones, we're gonna cut that KVP by about 10. Because we don't want to burn out the sinuses, and we're also collimating down a lot smaller than what we would for full skull imaging. So that's important too. All right, let's talk about positioning. Let's go over positioning. AP position. So your patient's up against the bucky. What are we lining up? What needs to be your OML, right? Needs to be perpendicular to the grid, to the bucky. So you're gonna have that patient, you're not gonna have them look down, you're just gonna have them tuck their chin in. You're gonna do that awful double chin.
So you put their forehead on.
PA, we're doing AP. AP, we're looking at this way, their head's against the bucky right here. Tuck their chin in so that the OML is perpendicular to the bucky. And then where does your central ray come in? At the level of the nasion. And is it angled at all? No, it is just straight in, just perpendicular right there. So when we take a picture, what we're looking at, remember that we want to see that this space between, sorry, this was recorded and some of the slides move on their own. I think there's a ghost in it. Can't get rid of it. Okay, so where do we want our petrous ridges to be for an AP? We wanted to fill the orbits. We wanted to see it clear up there at the top of the orbits. We also want to look at the edge of the orbit to the edge of the skull right here. And if we want it to be pretty equal on both sides, that means our patient's not rotated at all. They're nice and straight. And again, for this one, you'd probably open your collimation a little bit more and get down to about the level of the top of the teeth. But this is what we want to see. The petrous ridges are filling the orbits. Any questions on an AP position? All right, you're going to open that collimation up and get your full skull. So AP towns. AP towns, your patient is in the exact same position as they are for an AP. What we're changing is the angle on the tube. So they have their chin tucked in, their OML is perpendicular to the bucky, but now you're going to take your tube and you're going to angle 30 degrees caudad. Where does your central ray enter? Right here at the hairline, right up here, the hairline. So remember 30 degrees for OML, but 37 degrees if you're using the IOML to line up your patient. This can be done in a PA position. Remember, if it's PA position, it's called the Haas method. What are you going to do with your ankle if they're PA? Opposite, right? You're going to have a cephalic angle of about 25 degrees. So if you come in into contact with a question that talks about the Haas, just remember it's a reverse towns. Everything's reversed. Your patient positioning is reversed. Your angle's reversed. So keep that in mind. All right. So what do we want to see on a towns? What needs to be in the middle right there where that circle is? Do you remember what it's called? It's part of your sphenoid bone. Dorsum sella and your posterior clinoid processes, right? They should meet right here in the middle. Your petrous ridges are kind of funky looking because of that angle. Do you guys remember me teaching you that I was abducted by an alien from my townhome? Do you remember that? So towns, your AP, you're looking at your alien, and then your alien comes up on your picture, right? It kind of looks like a little alien emoji. So that's how it should look. Any questions on a towns or a Haas?
So you're still following like the angle and IOML.
Yeah, you are. Yep. So OML is 30 degrees caudad, IOML is 37 degrees caudad. And if you're doing a Haas, it's about 25 degrees cephalic either way. So, okay, let's talk about a lateral skull right here. A couple different ways you can do this. This is probably the most common way right here is just to have your patient kind of get their shoulders out of the way and place their head right against the bucky. You want to center about 2 inches above the EAM. So what is perpendicular? What line is perpendicular? Your IPL. You're going to look in their eyes and see that the IPL is going to be perpendicular to the bucky, their interpupillary line right here. Yes.
One textbook told me that the lateral skull you'll be whatever side the side goes down. But I didn't read that no. So that's true, like if they're left side of their head, you're gonna be on the left side or the right side.
I would think that would make more sense because it's closer to your IR as well. So it's going to reduce your OID. You should be able to see the side closest to it. The thing you want to look for is what are you looking for to make sure that you did a good job positioning? Sella turcica. You should just see one. This little saddle right here, you should just see one of them, not two. You also see pretty close approximation of your occipital bone on your frontal bone as well. Are they gonna be perfectly superimposed? No, because you have that OID, right? But they should be pretty close. So that's what you wanna look at. For your full skull, you wanna open your collimation up. You wanna get down to about the level of the mandible and get the entire skull. So a lateral skull, if you're doing facial bones or sinuses, is pretty much the same patient position, but you center differently. And we'll talk about that more in a minute, but just remember for a full lateral skull, you center about 2 inches above the EAM. You can also do this like you do a C-spine. You can have the patient just straight. But what are you gonna have to do with your SID? Yep, you're gonna have to put about 72 inches for that. Okay, any questions about the lateral? What do you do with your mass on a lateral? About cut it in half, yes. Okay, Caldwell, PA Caldwell. We should have talked about PA first. Let me see if PA is on here. Yeah, let's talk about PA first. So for a PA skull, it looks basically the same as your AP, right? Where are your petrous ridges? They're filling the orbits. It looks a lot. Sometimes it's hard to tell the difference between an AP and a PA. They should look the same. It's just our patient position is different. So do you remember when we're doing a PA, what's up against your Bucky? Forehead and your nose should both be up against the Bucky. That's going to bring that OML so that it's perpendicular. So forehead, nose against the Bucky, no angulation. Central ray comes in the back of the head and exits at the same level. Nasion, right? Collimate for the entire skull again. And you should see the petrous pyramids filling the orbits. Okay. Caldwell. So again, your patient is in a PA position, just like for your PA. He's got his forehead and his nose against the Bucky. You can see right there that his OML is indeed perpendicular to the Bucky. But what are we doing differently for a Caldwell that we didn't do for the PA regular? 15-degree angle, right? Caudate angle. So do you guys remember the way I taught you to remember how a PA is positioned? I mean, not PA, Caldwell. Yeah, he's going, hey, Andy, you goonie, right? He's coming down the well. So that's how he is. His face is against the Bucky like this. And what are we looking at?
Yeah, I have another thing to help you on this one. I love that saying OML, he fell down the well, because the OML is the one that's perpendicular.
Love it. Thank you, Janine. OML, he fell. Oh my Lord, is that what it means? Okay, OML, he fell down the well. Where are your petrous ridges at?
Lower third. The well is a third of the way full of water. Too.
Right. That's what I think of Goonies, and I think that they're in that water diving for their coins, but they could look up and see Troy at the top, right? So yeah, your petrous ridges are in the bottom third of your orbits, right? Again, you want to look at the lateral edge of the skull to the outside of the orbit, and it should be equal on both sides, showing that you don't have rotation on your patient. You see some nice pictures of the sutures there. We can see those frontal sinuses. This is a great one for orbits if we're looking for blowout fracture or something like that. So Caldwell. Okay, SMB. This is what I call the flash dance position right here. If you're young, you're probably not going to get that joke. If you're old like me, you're going to get it. Did anybody ever see flash dance? I think they even make fun of it on a cartoon or something now. But the girl's in the chair with her head thrown back and the water splashes all over her. So this is the flash dance position, SMB. Kind of hard to do. You're going to have your patient, remember that you don't want to have him on a scooting chair, right? You want a nice stationary chair that has a back to it, because then you can scoot your patient to the edge of the seat and have them lean back against the backrest, and their head's naturally going to fall back. It's going to be a lot easier than them trying to hold it back. So use something with support. The top of the head should be against the Bucky. And then you're going to take the little gonions right here and draw that imaginary line. Your central ray is going to go straight in. What if I have a patient that can't get their head back that far? What if they can only go this far? You're going to angle so that you're perpendicular. If they're all the way back, it should be perpendicular. If they're not, it's going to be just angle. So you can get it in there. Okay. What do we see on an SMV? What are we looking at? Zygomatic arches a lot of times. We do mandible imaging this way. What sinuses can we see? Can't see the maxillary so much. Yeah, you've got your ethmoid and your sphenoid sinuses right there. So sometimes we'll do this for a sinus position. Where do you want your teeth to be on where the skull is? Like how close? How far above the skull should your teeth be? Pretty lined up, or about a ½ inch above. You don't want it below. Should be pretty lined up though, like this. If you look at this, the IOML is parallel to the cassette in this position. And the mid-sagittal plane is perpendicular. Any questions about SMB? I should have just thrown some up here and had you guys tell me what they were, huh? Tested you a little bit. All right, Waters view. What do you do for Waters view? Are they AP or PA? They're PA. What's against the Bucky? Their chin. Is their nose against the Bucky?
No.
No, it should be about 3/4 of an inch away from the Bucky. Where does your central ray go in? Where does it exit? Exits the acanthion right here. So if you look at this, the OML is making a 37-degree angle with your Bucky, with your IR. Exits at the level of the acanthion. This is another good one for blowout fractures. You can see those orbits really, really well. Where do you want your petrous ridges to be? Does anybody remember? Below the maxillary sinus. That's right. What am I doing if I take my patient and I tip their nose to where it's touching the Buckies? What's that called? Modified Waters. We do those as well for sinuses and for orbits. Where should your petrous ridges be for a modified Waters? Yeah, they should be mid-maxillary sinus. Why would you have your patient drop their mouth open? Which sinus? Sphenoid sinus, yes. You should be able to see if the ethmoid sinuses are up here in the upper part of the nose between the orbits, but if they drop their mouth open, you can see the sphenoid sinus. So if you ever do a Waters for sinuses, you're gonna want them to open their mouth. Open mouth Waters, exact same patient position, they just drop their chin and open their mouth. All right, any questions yet? You hanging in there? Let's talk real quick about facial bone imaging. Facial bones, we have 14. Remember that most of these are paired. Do you guys remember which ones aren't paired? There's only 2 bones in your face that aren't paired. Mandible's one. Vomer, yeah, your vomer is the other one. So occipital bone is not considered a facial bone. It's all up here in the front. So we have a maxilla. We have 2 of them. That's the yellow one over there. We have the zygomatic, which is the green. We have the palatine bones, which are the L-shaped bones that are up in the nose. What do they help form? With the maxilla, what do the palatine bones form? The palate, the roof of the mouth. You've got 2 little nasal bones right up here. You've got the lacrimal bones, which are right in your tear duct area. You've got your nasal concha, the little green ones up in the nose area. And then the not paired bones are the vomer and the mandible. Okay, so when we do facial bones, it's exactly the same patient positioning that we just talked about. What's the difference though? Collimate, you might center a little bit differently. So where do you center for a lateral? Yeah, so it's kind of on your cheekbone right here. So when they're in a lateral position, it's right between the outer canthus and the EAM. So it's right here in the cheek that you're going to be centering. You collimate down. Do you need the whole back of the skull for facial bones? No. So collimate down, get this nice picture right here. Again, look at your sella turcica, make sure there's only one. Which of these views is the only one that you can see all 4 sets of sinuses? Lateral is the only one. We can see frontal sinus, maxillary sinus, we have the sphenoid sinuses, and then we have the ethmoid sinuses right there. So all 4 sets of sinuses. Okay, we'll also do a Waters to see some sinuses right there. This is really good to show, especially like air fluid levels in the maxillary sinus. And then we also will do a Caldwell. How do we do a Caldwell? They're in a PA position. What's our central ray doing?
15 degrees.
15 degrees cauda. And where is your petrous ridges? Lower third. All right, you guys got it. Good. Nasal bones. What's the key with nasal bones? Do you need the whole entire half of the face like you do for facial bones? Nasal bones, you're collimating down to just the nose. So where do you center for a lateral nasal bone? Just like right behind the nasion, right behind, and you're just going to cone down just really, really small. Central ray goes in perpendicular. You should get a nice little picture like that. Nice little broken nasal bone right there. Okay, let's review orbits really quick. Has anybody done any skull imaging lately? Okay. What's another good one for nasal bones?
Let's see, we do.
That one? Waters. That actually shows if it's displaced this way or this way, right? What else do you do?
I don't think, sorry.
It's a long day. I totally get it. Let's just talk about the orbits. Okay, orbits, you're gonna do a waters view, you're gonna do a lateral view, you're gonna do your Caldwell, and then you're gonna do maybe a modified waters too, modified waters or irregular waters. So again, the Caldwell is in a PA position with a 15-degree cut-out angle. You should see the petrous ridges in the lower third. There's your, what is this over here? That's your waters. And where's your petrous ridges in that one? So that's mid-maxillary. Do you see the petrous ridges in the mid-maxillary? So what kind of a waters is that? That's your modified waters. And then again, here's your lateral right here for orbits. Okay, let's review mandible imaging. Has anyone done mandible? Do you have, yeah, you're doing a lot of skull.
Yeah.
All right, so just remember, we have the ramus, we have the body, and then we have the mental point. So sometimes when people get punched in the face, they get punched here, they get punched here, they get punched here. If they're in an accident or they're hit with a softball, it could be different parts. Wherever their injury is, you're going to image it a little bit differently, right? So when we do mandible, we're going to do an axial lateral. Well, we might do a PA skull, but you're going to center at the lips. We're going to do a Towns, but you're going to again center down lower, and then an SMV as well. Let's talk about that axial lateral though, because that's the confusing one. So again, it depends on what part of the mandible you're looking at. If you're looking at the ramus, you're going to have your patient be pretty much in a true lateral, and you're going to direct that about 25 degrees cephalic, right at the gonian right here. So that's going to show the ramus a lot better because it's right up against the buccal. If you're looking at the body, this part right here, you're going to actually rotate their head a little bit more. You're going to rotate them so that the body is up against the IR right there. So that's about a 30-degree rotation towards the buccal with another 25-degree central ray. That's cephalic. If you're looking at the chin, this is our point of interest. We're going to rotate them even farther so that their chin is up against the buccal. It's about a 45-degree rotation towards the IR and still have that 25 degrees cephalic angle on there. So any questions about the axial lateral? Okay, TMJ, anyone do these? No, they're pretty obsolete. Do you guys remember what you do for TMJ? Open and closed, yeah. Hey, who did that? Okay, so your TMJs are right here. It's this little joint. You can feel it. It's the only joint in your whole skull. What kind of what?
Joint is it?
Hinge joint, I think. Yeah, that's a hinge, right? Okay. I have a dirty joke with that, but I don't think it's appropriate to tell you guys that. So, yeah, now I'm distracted. Okay. So we're gonna do an SMV and we're gonna do laterals. And we're gonna do two laterals. We're gonna do open mouth and closed mouth. All right. So let's talk about the SMV a little bit. You're just gonna have them all the way back. You're gonna angle again, or not angle, but go in straight right here where that gonian is and take an SMV picture. And usually you can see the little condyles of the mandible really, really well. When you do your laterals, you're going to do a 30-degree caught-out angle. You're going to center a couple inches above the EAM. You're going to do both sides usually. You're going to do right and left laterals, 2 pictures each. So you're going to do a closed mouth and then have them stay exactly how they are and open their mouth. And it's going to show the difference in that joint movement right there. A lot of people that have TMJ pain, it's usually the ligament that connects between those bones that's usually injured. So a lot of times we'll actually do these like an MRI now so that they can actually see the ligament, because it's not telling us a lot of information when we look at the bone. But just so you know, remember that it's an open and closed mouth. Okay, let's go into sinuses really quick right here. Sinuses, so we talked about we have 4 sets of sinuses. We have our frontal sinus, we have our maxillary or ethmoid, and our sphenoid sinus. If you get an order to do a sinus view, it usually includes a lateral, usually includes a Waters, and it usually includes a Caldwell. Do you remember what you need to do with your horizontal ray for any kind of sinus imaging? What do you do with your central ray for sinus imaging? You're not supposed to angle, right? You want it to go straight, because what are we looking for sinus imaging? Air fluid levels. And so if we angle at all, it might throw that off. So we want to do everything with a straight horizontal ray. And remember, what are you going to do with your KVP? Decrease it by about 10, so we don't burn those sinuses out. All right, so here's a picture of an open mouth water. Again, when we do this, we're looking at the sphenoid sinuses right there. We can also see really good maxillary sinuses on this one. Usually you open your collimation a little bit more because you want to see, a lot of times you can see the frontal sinuses as well on a Waters. And I think that's it for skull. What else do you guys want? Which part?
Yes.
Yeah.
Yeah.
Scotty dogs?
Yeah, it's like an animal.
Do you guys remember French fried chicken finger?
Yeah.
Do you want to go over that? All right. It's what?
Fresh fried. Says it's fresh fried.
I like fresh.
I've never heard fresh fried, but that makes more sense.
Yeah.
Maybe I'm a little deaf. Maybe I heard it wrong, but I swear they said French fried chicken finger.
It still works.
It still works. Okay, this is gonna save your life. All right, let's talk about French fried chicken finger. Okay, what is French fried chicken finger? What is it referring to? What position? AP oblique, not PA oblique. So anything that refers to RPO or LPO is going to be an AP oblique. So if you get any kind of a board question that might ask your patient's in an LAO or RAO, you're going to do the opposite of French fried chicken finger, right? So it only applies to AP oblique. So let's talk about obliques. If I'm in an oblique position, AP oblique, what part of the cervical spine am I interested in looking at? Well, I'm sorry, what anatomy am I looking at? Intervertebral foramina. Where do you see the xygohypophyseal joints for a cervical spine? In a lateral. All right, so that's the only place that you see it in a lateral. When we have a patient in an AP oblique, we're looking at their intervertebral foramina. If I'm in an AP oblique, what's my area of interest for the T-spine? What are we looking at anatomy-wise? Zygapophyseal joints. What about the L-spine? Zygapophyseal joints. What about your pelvis? What am I looking at? SI joint, okay? French fry chicken finger. C-spine, T-spine, L-spine, pelvis. Okay, so I'm in an AP oblique. Which intervertebral foramina am I looking at in my C-spine? Farthest. French. What about my zygapophyseal joints? Which ones am I looking at? Farthest. Zygapophyseal joints. Closest. SI joint. Farthest. Okay, if I'm this way, exact opposite. It's CCFC. If anyone comes up with a cool thing for that, let me know. It's just the opposite. Close. That works really well, actually. I was trying to think of a Raising Cane thing, but I couldn't do it. All right. So does French fried chicken finger make sense to everybody? Do you get the concept?
So for this, C-spine, you're looking at
The foramina. Okay, remember C1, what is it called? Atlas Y. It holds up the world, it holds up the skull, right? What rests right here on the anterior arch? What slides up there and rests right against it? No. Right here on this side. Your odontoid, right? From C2. What rests against the posterior arch? The spinal cord. So C2 looks really different than C1. C2 has the odontoid. It's a lot thicker and a lot broader. It has these guys also have these transverse foramen where your vertebral arteries go. None of the other spines have transverse foramen, only the C spine. And then C3 through C6 have bifid tips. Remember that, that's kind of unique as well. So are you pretty good with positioning? You want to look at Scotty dogs? Scotty dog. Let me see if I have it. Let's do the anatomy real quick right here. If you look at the L spine, we have the body. What connects the body to the arch? Pedicles. Pedicle, pedicle, connects the arch to the body. We have a superior articular process. We have an inferior articular process. What do those rest on? That's what stacks on top of each other. The superior touches the inferior of the one above it, right? And that is what forms your zygapophyseal joints.
What is the pars interarticularis?
The pars interarticularis is this area right in here. So kind of between the process, the inferior and superior processes. Yep, so that's your Scotty dog's neck right there. You got your you've got your spinous process, and you've also got your transverse processes right there. So when we're looking at the Scotty dog, this is his ear, that's his paw, that's his tail, that's his neck. Transverse process is his nose. And what's the eye? The pedicle. So let's look at a picture of a Scotty dog now. Okay, right there. Can you guys all see the Scotty dog? For me personally, I look for the little eye first, because then from there you can kind of find the nose and the ear. Okay, so what's the eye? Pedicle. What's his little nose? Transverse process. Here's his, what is it? Superior articular process, and it's touching this. What's that? This is your inferior articular process from the doggy above it, which creates the zygapophyseal joint. You guys all see those little joints right there, those little straight lines between the ear and the paw. Okay, so his neck is what? Pars interarticularis. His body is the lamina, and then his little tail out here is your spinous process. You want to always see the little eye of the Scotty dog kind of in the middle of the vertebral body. If it's on the anterior side or the posterior side of that, he's either under or over rotated.
Okay, remind me which one is which, because it's backwards.
I
So
think,
if the eye is too far back.
I think if the eye is too far forward, he's under rotated. Don't quote me on that, 'cause I can't remember.
Backwards in my mind.
It is mine too. And I think if it's on the posterior side, it's over rotated. I can't remember. I think that's what it is though. Yeah. The set joints? Yeah.
Okay.
And sometimes they're called apophyseal joints too. So yeah, they're all pretty much the same thing. So when they do like facet injections in people, that's what they're looking for right there. Okay, any more questions about the Scotty dog? You got it down? Let me see if Rob's about ready to come teach you fluoro. Fluoro's so fun. Did you guys, this wasn't your group, no. I was in here teaching, we had such a big group one year that we taught all of our first year students in this room every semester. And were you guys ever in lab when we did the fart machine?
No,
You didn't ever see the fart machine? Did you see it? Yeah, well, Rob and I were team teaching a class one time. He's sitting up here, and unbeknownst to me, he hides the fart machine over here under a big pile of t-shirts. And as I'm walking around teaching, I hear this. And of course, my feet was quite red.
She knew it was a joke, but not the students.
I thought it was so I didn't say anything. I just kept going. And then afterwards, I'm like, "Do you guys hear that?" And they're like, "Yeah." I'm like, "Do you think it's me?" And they're like, "Yeah." Yeah. Oh, golly. So it's recording right now, and Tanya said, "Will you please log her out after you're done teaching?"
Because you're supposed to be done at 7, right?
Yeah.
I just texted Tanya and said, it's 7 o'clock. Do you want to just record my piece, post it?
I'll leave it to them.
We'll keep you late.
You guys want to stay here late? You want to keep going?
I say finish it.
I mean, it's recording anyway, so if you want to just, I don't know. if
Yeah, just
you want-
finish it.
Okay,
Y'all are at the tail end.
hold on, Tanya's texting. She said, ask what you guys like. I can either, okay, I can record my piece and post it, and you can watch it, or I can just get it done now. What do you think?
Yeah, he's gonna stand here and record anyways. There's people online too that are watching.
Will you just be able to give us a little bit more of a breakdown if you do a video too? Like,
Can you go into more into depth if you do a video later?
Sure.
Okay.
Okay, I like it.
Yeah, yeah. I like it.
That was easy.
I can do it tomorrow. I can do it tomorrow. So what I was gonna do, I only have 30 minutes with you. I was gonna go over Florida.
Yes.
You guys want Florida?
Yeah. That's but not like all the post images after you do like an African and all that stuff.
Like a week.
Yeah, like, yeah. we're here to yeah, we're fun, want to be here, fun.
Yep.
So if you guys heard that online, Rob is going to record his part on fluoro and post it for you guys to watch, a more in-depth lecture. So we're gonna go ahead and end this PowerPoint tonight. Thank you guys for being here.
Thank you.